Good afternoon, and welcome all commissioners and HPC staff and those members of the public who are joining us on our live stream. Welcome to our June board meeting. We have several important topics that we're going to cover today. First, we're going to hear from the research and cost trends team, who's going to begin to present findings from the upcoming 2023 annual healthcare cost trends report. That report will be slated for release in September, but we'll be able to review the findings at the next couple of board meetings. We'll then follow up with the market oversight and transparency team, who's going to present policy recommendations for reducing unnecessary administrative complexity. This was a topic that was covered at last month's MOAT committee meeting, but we ran out of time to fully present those recommendations. So we're looking forward to the presentation today and board discussion of the HPC's role in supporting and furthering efforts around administrative complexity and reducing unnecessary administrative complexity. Then our legal team is going to share an update on out-of-network billing, including the progress that's been made on implementing the Federal No Surprises Act and related updates that impact Massachusetts directly. And then our executive director, David Seltz, will close out the meeting with his report and brief the board on the agency's progress on its 2023 action plan now that we've gotten through the first half of the year. Our first order of business is to vote on our minutes from the last board meeting, which was on April 12th. And I'll turn it over to Acting Chief of Staff Hannah Klumek to take us through the process.
Great, thank you. Can I get a motion to make that vote?
I'll move.
And is there a second?
Second.
Turnbull, I'll start with you.
Yeah.
Vice Chair Cohen,
Aye.
Commissioner Berwick,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Castillo,
Aye.
Commissioner Cutler,
Aye.
Commissioner Foley,
Aye.
Commissioner Hoop,
Aye.
Commissioner Master Giovanni,
Aye.
Commissioner Kwasnick,
Aye.
and Commissioner Singh.
Aye.
Okay, thanks so much, Hannah. Thank you all. And I'd now like to turn the agenda over to Commissioner Berwick, who has an important announcement.
Thanks so much, Madam Chair. My announcement is with enormously mixed feelings. For a number of personal important reasons, the time has come for me to leave the commission, and I have submitted my resignation. I didn't want the moment to pass, however, without a few words, Madam Chair, of thanks for the chance to serve. This has been a highlight of my professional career, extraordinary privilege to be part of such a pioneering move, not just for the state, but for the nation, and to work with such an extraordinary group of colleagues. The staff of the commission are the jewel in the crown. I have worked with staffs in Washington in both the Hill and the White House, with many nonprofit organizations, with ministries of health around the world, and with many foundations and think tank organizations. I will say without any equivocation, this is the best staff I've ever worked with. Extraordinarily talented people, not just committed, but their capacity and ability to do very hard work supremely well is just extraordinarily impressive. That's a credit to them, and David Seltz, a credit to you. Your leadership of this commission is, to me, stands as a benchmark for public service and for professionalism. And I just thank you for your leadership. And to my fellow commissioners, what a pleasure. You all have been a source of enormous pleasure and inspiration for me. We've worked through some hard matters with grace and dignity and respect for each other. I will delude myself into thinking that I'll be able to maintain close personal relationships and professional relationships with every single one of you. So, Madam Chair, I just want to thank you for the chance to have served under you and to express my my gratitude for having been part of this enormously important effort.
Thank you so much, Commissioner Berwick. We have benefited greatly from your 7 years of very generous service, which I've experienced both as a citizen and now had the honor to serve as your fellow commissioner. Dr. Berwick was appointed by Attorney General as a healthcare consumer advocate, and the HPC has benefited so much from your deep experience and impact as one of our nation's leaders in healthcare improvement. Your focus, Dr. Berwick, on the balance between quality, safety, and cost has really served the Commonwealth greatly, and your view in every issue that's come before the commission, that healthcare is a human right, has been felt by all who have served with you and who have worked with you during your service as a commissioner. I'm so glad that you indicated your willingness to maintain relationships, because I hope that we can continue to benefit from your insights and advice as we move forward. And we wish you every happiness as you continue your work on healthcare quality, cost, and safety.
Thank you very much.
Any other commissioners who would like to speak?
If
I
could,
would. I'm sorry, I'm butting into somebody, but I never got the opportunity to really get to know you. But I know so much about what you've done, and as I wrote you a chat, I wanted to spend that time learning from you. So I hope I'm one of the people that you reach out to, because I have a lot to learn from you. So I'm grateful for the time we had together.
Thank you so much, Mr. Castillo. Commissioner Cutler?
So I count myself as a longtime friend of Don and a student of what he's done, which has been just absolutely remarkable. I'll just say one thing, which is, as an economist by day and economist by night, it's rare that you find someone who will bring such a moral lens to economic issues. And Don, you've done that. Better than anyone is sort of understatement, like better than one could ever have imagined that someone could do that someone could sort of take numbers and say, well, what is the moral dimension that underlies them, and what do they, like, honest to goodness mean to people? And that's just such a valuable skill and thing that you've taught us all. So I'm hoping that as we go forward, we can keep the numbers, but every time we hear a number, think about who is the individual underneath that, or who are the individuals underneath that who are really being affected. And so if we can do that, I hope that'll be a testament to Don. And if we fail to do that, I hope Don will call us out on it in the future.
So you hear that there is still a role for you, Dr. Berwick. But we will thank you again, and we look forward to, I'm sorry, Barbara, Commissioner Blakely.
Thank you, Madam Chair. Don and I have known each other for probably close to 20 years, and we worked together when he was the director of CMS, and I was in DC in terms of some of the greatest partnerships to try to find solutions to safety, quality, and outcomes. Don, I happen to have ended up being a fellow in the CMS Innovation Fellowship Program that you designed, but we're not there to see to fruition. And I thank you for creating that, because it was a pivotal experience in my career, and I appreciate that opportunity. But most importantly, Don, I'll miss your wisdom, your ethics, your powerful reasoning here on the commission, and I hope you keep a close eye on us, and I hope you let us know how we're doing from time to time. You'll be missed, my friend. Thank you so much.
Thank you. Commissioner Tsang?
Thanks so much, Chair. We'll keep this brief. Don, as someone who served as healthcare division chief under then AG Healy, now governor, who originally appointed you,
I think there aren't words to express the extraordinary impact that your service has had, and the light that your voice has represented in different places, many, many places, whether you're in the room or not, and to so many, including staff and others doing what you describe as the unsung work. What you would wish to convey in one sentence is that you have set the bar for the consumer voice at this commission. Thank you.
Very well said. Any other commissioners that want an opportunity? Okay. Good.
Yeah, Madam Chair, I'll just add, I think we need a sign, W squared D squared. What would Don do to make sure the voice of the patient remains foremost in our minds as we tackle these issues? Don, thank you. It's been a pleasure working with you.
Thank you, Marty.
Terrific. Thank you. Thanks so much. So we'll now move forward to our first formal agenda item, and I'll turn it over to Executive Director Seltz to introduce us.
Good afternoon, Madam Chair. Good afternoon, commissioners. It's great to be here with you today. And first, I'll just start by offering my own sense of gratitude and appreciation for your leadership and support, and frankly, friendship over the years, Commissioner Berwick. You have been so incredible to work with in these meetings. You are quick with a compliment, followed by an insightful, stumping question. But we will also miss you in between these meetings when you were so graciously offered your expertise and time to the HPC staff. So on behalf of the HPC staff, thank you. And we look forward to staying connected with you in the future and calling you up on the Berwick bat phone. We have a tremendous amount of material to present today, and on three really weighty topics, on our cost trends report, on reducing administrative complexity, and on out-of-network billing and the No Surprises Act. So while we have a lot to present, I really do want to make sure that we take the time to really have a dialogue and engage in a conversation. So please, commissioners, we're going to be presenting, but stop us along the way, raise the hands, interrupt us. We really hope to make this a really discussion-filled conversation today, even as we're going to be presenting a lot of new material for your consideration. So the first topic of the day is a preview of findings from our annual cost trends report. The cost trends report is our signature publication of the year as set forth in our enabling statute. It is a report that does an annual deep dive into the data to try to understand the drivers of healthcare spending in Massachusetts, to identify opportunities for efficiencies, and ultimately to make policy recommendations to the legislature, the administration, and to market participants. So for today, what we're planning to do is provide you an overview of some of the highlights from the report that we've been working on and the accompanying chart packs. This report is obviously still in development. We plan to bring the full written report to the board for consideration in September. So really the goal of today is to get your immediate input, feedback around some of these findings and how we might contextualize them in a report, and what policy recommendations we may want to include in our report informed by these findings. So with that, I'm very happy to turn it over to our research and cost trends team, led by David Auerbach, to begin this presentation.
Okay, thank you, David. Okay, we do have a number of slides, but we'll move through them as quickly as we can. Hopefully not too fast. Okay, so here's a bit of just framing for what we're going to see here. We know as a top line finding that commercial healthcare spending per person in Massachusetts grew pretty quickly from 2019 to 2021, about 5% per year each year. And that's double the rate that income grew. As a way to place that in context, average health insurance premiums plus out-of-pocket spending for a Massachusetts family approached $25,000 per year in 2021. So overall, this trend of spending growth faster than income is unsustainable for governments, for employers, for residents. And when we know that when premium growth grows faster than income, it erodes take-home pay, it increases people's avoidance of care, it worsens health outcomes, and it requires people to choose between healthcare and other basic needs. So given that, we know that we have to limit the growth of healthcare spending. And in light of the fact that we know that we want to increase spending in some other areas, such as primary care, behavioral health care, and health equity in the workforce for under-resourced providers, we have to find areas where we can spend less quickly. And so that's the main theme of this 10th annual healthcare cost trends report, is trying to identify those areas where spending is excessive. And we're really returning to a theme from the very first cost trends report, where we talked a little bit about that as well, which was inspired by some work by Don Berwick of excessive spending in healthcare. And we're not just looking at places to cut overall, but where savings are achievable within the current system, and importantly, without harming quality and access to care. So those are going to be the two main topical chapters of the cost trends report. And on the next slide, I'm showing the outline of the report as you'll see it. Chapter 1 is our overall trends in spending and spending growth. Then chapter 2 and 3 are the new topical chapters. So we're dividing excessive spending into really these two broad categories of excessive prices, which we talked about in our last meeting, and then potentially excessive utilization, which has two subcategories that I'll cover today. Utilization of care that adds little to no value, and then where people are using care in an unnecessarily high cost setting of care, more than necessary. And then we'll have also some discussion of excessive administrative costs as part of this chapter 3. Then we'll have our 5 chart packs. One of them is new, primary care and behavioral health, which is coming from a mandated report by the legislature for us to talk about that. And so today we'll spend most of the time going over key findings in this utilization chapter 3 and in the chart packs that come after that. And we'll talk about our dashboard and recommendations at the next meeting. Okay. Before getting to that new material, I'm going to recap a little bit of the material from the last meeting on the first 2 chapters. Okay, so let's move on. Starting with the overall benchmark, which we've all seen, just to have everyone be reminded of that. Total healthcare spending in the state was negative. It dropped in 2020, and then it increased 9% in 2021 for over the course of the 2 years on average, 3.2% growth. And if you look at the 9 years from the very beginning, where we've been under the benchmark, 3.52% growth is the average annual. Now focusing on just the commercial spending trend, which I noted was unusually high in the last 2 years. You can see Massachusetts in the orange. Our commercial spending growth had been below the US average pretty consistently from 2013 to 2018. And then since 2019, we have been above. So you really see a reversal or a change in that trend. And then in the next slide, we're showing just the long run accumulation of commercial spending growth in particular. This slide really goes back to 2000, but it's showing that over that 20-year period, our employee premiums in Massachusetts have grown 3 times faster than household income. Total family premiums have grown 200% over that period. And then you see that in comparison to household income and general inflation growth down at the bottom, much lower than the growth in commercial spending. So this is the main concern, and these commercial costs have increased in the last couple of years. And the next slide is going to highlight just some of the drivers of that spending growth by category of care. Here we're showing, again, in a lot of these slides will show kind of smoothed over 2019 to 21 average growth to avoid that big drop in 2020 and then the increase in 2021. And so here are our usual categories where we separate out spending, and you see the higher growth in pharmacy on the right of 7.3% per year. That was the only category where there was not a drop in 2020. And you see that steady increase. And then in the hospital outpatient category towards the left, the second highest growth of 5.5% per year. And within that, the facility, the spending that goes to the hospital is the dark blue, and the spending within that category that goes to the physician fees, the professionals, is in the light blue. And it's that It's the facility part that is driving most of the growth there. And we'll come back to that in later slides. Okay. Next slide, please. Okay, so that's a quick recap of some of the initial chapter in the report. And now I'm gonna go into some of the new material and utilization. But before that, I'll just summarize a few slides of what we presented in May for those of you that weren't able to attend that committee meeting. So what we did in that meeting was we defined what we considered excessive prices in the commercial sector for healthcare services. And those were defined differently for different categories of care, but we focused on the categories where we felt spending was and prices were likely to be most excessive, where there was particularly market leverage in some of those commercial prices or in prescription drugs, which we know about. So the definition differed a bit, but those excessive prices, we usually used double what Medicare would pay as a benchmark or a sort of a price limit above which we considered prices to be excessive. And then we went through each of these categories of care and asked how much were commercial payers paying for different services relative to Medicare and relative to our excessive spending definition. And then summed how much spending was there above those price benchmarks. And so I'll show just one example as a recap from last time's meeting in the next slide. And here we're looking at imaging spending, MRIs, CAT scans, X-rays. And so what you see here is a histogram, is a distribution of commercial prices compared to Medicare. So on the X-axis, you'll see that Medicare price is defined as 100%, and that's that dotted line way to the left. And then a little bit over is our defined excessive price limit, and that's 200% of Medicare, and that's what that dotted line represents. We've also separated the services into where they occur in a HOP-D in the gold and where they occur in an office setting in the blue. And what you see here, for example, is that about half of all imaging services that took place in a HOP-D were paid more than double the Medicare price. That's all those gold bars. You see a lot of volume in the 300%, 400, and even 11% of services were paid more than 5 times what Medicare would have paid. And so in total, if you add up all that spending that is above the double Medicare price point, it amounts to 22.5% of all imaging spending we consider to be excessive by this definition. And so then on the next slide, you'll see the tabulation of all the categories of care that we considered: labs, some specialty services, imaging, colonoscopy, inpatient stays, and so on. And for each category, you see the amount of spending in the baseline on the left. And these categories accounted for about half of TME. We didn't look at primary care, we didn't look at everything. But of the half of TME we looked at, we found that about 27% of spending was excessively priced. 27% of spending was above our excessive price limit. And so that amounted to about $3 billion in commercial spending, or 12.5% of all TME was excessive due to high prices. Okay. And so we will continue to refine that section, but that's kind of a quick summary of what we found. Okay, now we're going to move to excessive utilization. And we have a few slides here. So this is a slide we've shown before. Continues to be somewhat surprising that, again, we're looking at our Medicare population because it's the easiest way to compare across states. We have good apples to apples populations and programs. We know that our avoidable hospitalizations among this population is the 4th highest in the country in 2021. We're after West Virginia, Louisiana, and Kentucky. We then tried to look into this a bit further. And just so you know, avoidable hospitalization, this is defined as hospitalizations for chronic conditions, COPD, asthma, hypertension, CHF, and so on, that could have been prevented or treated outside an inpatient setting. Okay, so we looked at some other hospitalization categories. Readmissions on the next slide. We've known that we're always high in this category too. Here we're the 5th highest. All-cause Medicare readmissions within 30 days, we're the 5th highest. We stepped back a bit from that, and on the next slide, and I continue to be surprised that now we looked at just overall hospitalizations for everything, and we were the highest, the single highest state. To say that again, our Medicare population has more hospitalizations than any other state in the country, 247 per 1,000 beneficiaries. Okay, I'll pause there. Is there a question? Yes.
Commissioner Walsh?
Sorry, you're muted.
Ask if the Medicare readmission rates were adjusted for behavioral health, because what I saw in my last life was that the BH readmission rate for, this is the Medicaid population, not Medicare, was 30% for inpatients. So I just wondered about, so that's all cause including BH?
It's all cause including BH. Yeah, I know that from Chia's reports that BH is an important factor in readmissions. That's right.
Okay.
And I don't know for more or less than other states on that, but that's a good question too. Yeah. Okay, it's all cause. So here we are, it's not just the avoidable hospitalizations, but it's all hospitalizations where we are extremely high. And then on the next slide, we wanted to check that to see, is there something about the health of our Medicare population, or are we older? We adjusted for those things and we're still the highest. And in fact, thinking about it this way, what this slide shows is how many hospital stays did we observe among a state's Medicare population compared to what we would have expected? And in this case, we had 20% more than expected, which is 67,000 hospital stays more than we would have expected. That's almost 10% of all hospital stays in Massachusetts in 2021. So that's a striking finding as well. That would certainly reduce some of the strain on our workforce if some of those hospitalizations didn't take place. But we don't have a lot of insight into really why this is, but we tried to answer that question in the next couple of slides, digging a little bit deeper into that. So on the next one, we then got data. Here we're expanding beyond our Medicare population to all payers. And we wanted to ask, what kinds of hospital stays are we high on versus where are we not? And so we found 35 comparison states, most of the other states. And we were able to look at maternity-based hospitalizations, at hospitalizations that are scheduled versus coming through the ED, and then those that come through the ED. And we were not high on the maternity or the scheduled admissions. It was only those that come through the ED, where again, we were the highest. This number means out of all emergency department stays, what % are then admitted for a full hospital stay? And here we were the highest, 17% compared to all other states. And so again, that was a striking finding. We don't exactly know why. We dug one level deeper on the next slide to then try to ask, and here we had to get detailed data on the conditions people are being admitted for. And so we were able to use just 7 states to compare ourselves to. And we looked condition by condition to see where are we admitting a higher percentage of patients than other states are, what kinds of condition categories. I mean, here we just took the 25 highest volume categories and sorted by where we were particularly high. And you see on the far left, heart disease, there's a lot of congestive heart failure. We admit 80% of patients to the hospital there versus 55% among the other states. And then you have other conditions, COPD, UTI, pneumonia, things like that on the left. Interestingly, on the far right, the only conditions where we admitted fewer patients were behavioral health conditions, were schizophrenia and depressive disorders. So again, we don't know a lot of the why questions behind this data, but it's intriguing, and it's something that we certainly want to look into more and are open to any thoughts from anybody here as to where to go to try to understand some of this better. Okay, so I'll move on for now, and people can keep that in mind. Okay, so other categories of, we do have one. Okay, yes.
Thank you. On the previous slide, one of the questions I have, how do we determine whether an admission is unnecessary when we compare it to other states? How do we come to that conclusion? As someone who's not a physician, like, how do we know that?
Great question. I really should say up front, almost everything in this utilization chapter, we're not able to be as certain about what is exactly unnecessary or not. It's really just more suggestive. You know, we are continuing to have these conversations with clinical experts, but we're never going to be as able to be as definitive as one would like, except for maybe in the category of low value care, where that's a little more clear cut. It's a good question. Okay, so that's that section. We have a few more categories of overutilization to look at. We pick on avoidable ED visits year after year. And here we're showing some of those trends from 2019 through 2022. And these are the top categories of potentially avoidable ED visits. And you see here that in all of these categories, we are still below 2019 in the dark blue, which is good news. But they are almost all increasing. You see the big drop to 2020 and then usually increasing to 2021 and then increasing again to 2022. And so time will tell if these continue to increase over the 2019 level or if maybe there's some kind of sustained reduction. And the next slide, we're looking at imaging. Oh, there's a question.
Hi, I was just curious in terms of the last slide. I'm wondering if, I don't know if there's any correlation to the use of telehealth in some of these cases around the drops in particular. Obviously 2020 and 21 with COVID, everyone was trying to avoid the ED. But I wonder if there's some kind of correlation there with maybe an implementation of telehealth to triage some of this that has assisted. I guess it's more of a comment than a question, but I don't know if that's been something that's been discussed.
Yeah, I'm glad you mentioned that. We actually have another analysis that we're not showing here, but where we can go into the APCD, look at these same conditions and ask, were they treated in an ED setting, in an office setting, in urgent care, or through telehealth? And we do see that kind of substitution apparently going on. So you'll be able to see that in the full report. And that's, yes, absolutely great question.
Thanks.
The only thing there is we can only go through 2021 so far. Okay, Dr. Castillo.
I actually want to ask the question from the slide before that because I know I'll forget. You had like heart disease and you know, and certainly we're the utilizers of that, right? But what does the outcome happen? How do we compare to some of these other states with respect to outcomes of heart disease in those areas? So in one end, we're the healthiest, one of the healthiest states. And on the other, I mean, I don't know. I'm just, that would tell me if we're doing something right or we're not.
Yeah, that's a question we thought of too. And we would love to see if we can actually connect these to some direct measurable outcomes. And it absolutely is something we would need to know how to think about this. That's right. And we just don't have that yet.
Thank you.
But we'd love to be open to subjections.
Yeah, I'll just add on this point, you know, we know that we have one of the healthiest states, and I think is that because our residents are using the healthcare system more, or should we expect a lower utilization of our healthcare system given the fact that we have a healthier population and that we know that what drives health is not necessarily predominantly the healthcare system, it's genetics, environment, social determinants of health that often go beyond access to hospital care. And so kind of understanding the causality and correlations between these, I think is really important to try to understand. Is this a good thing that is resulting in better health? Or should we actually be expecting perhaps less utilization, giving underlying improvements in health? So I think we'd love to continue to think about that with commissioners.
Absolutely. Okay, great. Let's go to the next one. Then I think we have a slide on imaging, another category where there's no potential excessive utilization. Here in this slide, we have variation in a couple of ways. We know that we have more MRI and CT use than Canada, for example. When you compare countries and similar populations, we have 30% more. Then if you compare our Medicare population, Massachusetts is about the 12th highest in use of imaging among Medicare beneficiaries. And then expanding on that further, here we're looking at commercial imaging utilization by provider organization. And there's variation here too. So we are high as a country, we're high as a state, and then some provider orgs, there's more imaging than others. And the variation is about 30–40% across these provider groups. So this is again suggestive of more utilization than need be among some patients. Okay, next slide. And now we're going to move from excessive utilization to higher cost sites of care. And in this category, we're again coming back to our Medicare population, and we've known we use more hospital outpatient sites than physician offices for a lot of things. Here we looked within the Medicare population and we took the 25 highest volume ambulatory care categories and asked, are we having these services provided in HOPDs more than offices for each of these, and how much more? And for 23 out of the 25, the answer was yes. Massachusetts, higher utilization in these facilities. And on the far left, you see where that utilization was the differential was the greatest. And it's often your common E&M standard office visits, where we had about twice as many occurring in a HOPD setting as the average US state. And you can see as that goes from left to right. So that's a known phenomenon that we've talked about for a while. Okay, next slide. We then turn to, there are some other categories of excessive high cost sites of care, but I'm just highlighting a couple here. We haven't really looked at this before, but here we're talking about ambulatory surgery centers in contrast to hospital outpatient departments, where they're often performing pretty much the same exact procedures. And we took 15 or 20 procedures here that are relatively common in the ASC setting. And first of all, we compared prices in the yellow. What's the average price for the same surgery, the same procedure in a HOPD versus an ASC? So in these yellow bars, the ASC is defined as 100%. And so if you see for lens and cataract procedures, 179% means the average HOPD price was about 79% higher than the average ASC payment for the same surgery. And you can see those yellow bars are all over 100%. And they tend to be, on average, it's about 75% higher for the HOPD payment compared to the ASC payment. And then on the left, we're showing just how frequently are these procedures performed in ASCs in those little mini pie charts. And you can see the lens and cataract procedures is exceptional. It's almost 70% in an ASC. And for all those other services, they tend to be in the 10–20%. So substantial, but relatively minor. For example, colonoscopy with biopsy, about a quarter of all those do happen in an ASC setting. Okay, so there's potential for savings there if more of these did occur in an ASC. And then on the next slide is showing, interestingly, we have far fewer ASCs than most other states. We have the 6th fewest in the country per capita ASC settings. And this partly is reflecting, I imagine, a moratorium we had on new construction from 1971 to 2017. And within the world of ASCs, what are they doing? What do they tend to do? What services do they tend to do the most of? It's a lot of GI procedures, a lot of orthopedic and eye procedures tend to be what the ASCs do. So this is an area of, kind of a new investigation on our team. We can identify these in the APCD, and we will have more to come on this category of care. Okay, next slide.
Do you want to take a question?
Question on this one. Do you know whether how, or maybe we could get a view of how this lines up relative to the DON regulations in the state, which are you sort of allude to it in the moratorium, but it's more than just a moratorium, because that's been lifted for almost, well, we had COVID in the middle, but and then those states that allow physicians to own ASCs, I think there's some corporate form questions and some regulatory questions embedded in that. And, that's something we could take back to DPH potentially to take a look at from a regulatory standpoint, if that's helpful.
Yeah, I mean, I think that's.
Am I way over my skis as a relatively new secretary and commissioner?
Oh, no.
Oh, okay.
No, that's exactly right. There was under the DON program a sort of a regulatory determination of there was no need for that period of time that Dr. Auerbach mentioned. And then subsequent to that, there was an expansion and allowance for ASCs to be built if they were connected with a hospital system. And so there were, different regulatory avenues to pursue the construction of ASCs. But it is definitely related to the regulatory environment.
Yeah, so I think it may be the consequence of well-intended regulation, right? Or at least we should, I mean, that's something we should take a look at. Also, the ability to care for people has significantly improved in that setting. People are doing hip replacements same day now, and we're not able to do. So I think there's a to do for our folks to take a look at.
Great.
Yes.
And we will expand on some of those themes as we continue to talk about this topic as well. Absolutely. Great. Okay. Now I think we're at the end of what we were going to present. Can I see? That's right. So this is a summary, and I won't read this out. It's the same findings that I just showed. So now we're going to move into the chart packs, and we're going to start by switching to Lauren Nasuti, who's going to present the primary care and behavioral health chart pack highlights.
Thank you. I'm excited to share some key findings today of our new primary care and behavioral health chart pack. While this is a new publication or a new addition to our annual cost trends report this year, the importance of primary care and behavioral health services is not new to policymakers across the United States. Policymakers have been trying to increase primary care and behavioral health care utilization and services, as these are services that are relatively underpaid, and they are often associated with better health outcomes and more efficient use of healthcare overall. As mentioned earlier, also, we are, as put forth in the chapter 177 of the Acts of 2022, we have a responsibility to report on behavioral health spending trends. This was the act, also known as the Act Addressing Barriers to Care for Mental Health. So we'll be sharing some of that. CHIA, our sister agency, has begun reporting aggregate spending for primary care and behavioral health starting in 2022. Their initial report that was released last fall included data for 2019 and 2020. So I'll be sharing some of that data here today as well. Before we get into the data that we're presenting, though, I want to talk a little bit about the definitions that we're using. Most of our definitions for the data that we'll be presenting are based off of the CHIA reporting definitions that they have payers submitting their data to them. For primary care, spending is defined as professional spending on mostly office type visits, including sick visits, preventive care visits, vaccines, and there's some other services, but a large part of this is office visits. And all these services must be provided by a primary care provider, and they have a definition of primary care provider. And these include nurse practitioners and OBGYNs, as well as primary care providers. For behavioral health, the definition gets a little bit more complex. CHIA defines behavioral health spending using a combination of behavioral health diagnoses, provider taxonomies, procedure codes. It depends on the setting that the care is being provided in. And for behavioral health prescription drug use is actually included in behavioral health spending. And for that, we use specific national drug codes, or NDCs, to identify prescription drug spending related to behavioral health care. In addition, HPC analyzed trends in emergency department room visits and acute care hospital stays for all payers, and these are often based on diagnosis codes or our APR DRGs for inpatient stays. And we look at ambulatory visits for psychotherapy, and these are just defined by procedure codes. And because we are using the APCD for this, currently we are only looking at these in the commercial population. So moving to our next slide. Do we have a question? Yes, Ron?
Yes, thank you. Sorry to interrupt. Actually, it's related to the last set of slides. And the thing that hits me when I look at this and we look at all these costs, and you take things like imaging, which is, pretty profitable for systems. If we're able to cut back on those costs, what does it do to the financials of the hospital systems and also how does it impact our quality of care? Do we ever run projections on how we can do this and also reduce their costs as well so that we don't have an impact on their margins where they actually end up losing money at the end of the year? Do we look at that at all? Because quite frankly, I'm most concerned about the quality of care I get when I go into receive services. I was wondering if you ever look at that.
In the last presentation today, you could show us the hard question.
Really sorry, I can't hear you at all.
Yeah.
We showed an example comparing Massachusetts hospitals and the aggregate. And what we were showing was the trend in hospital revenue and then hospital costs after Rhode Island passed a constraint on hospital price growth in 2010. And what we showed in that graph was that the hospital revenues in the 8 years that followed grew half as fast as they did in Massachusetts. So that's an example, kind of like what you're saying. What would happen if revenues to the hospital were constrained? And so you saw that. And then the hospital costs in Rhode Island also grew half as fast as they did in Massachusetts. So the costs, hospitals were able to lower their costs in line with the lower revenues. And we looked at a number of quality measures and we did. So there's a lot more that could be learned there. These are aggregate quality measures. They don't measure everything, but that's one example where that suggests that you wouldn't have a problem, that the hospitals would be able to adjust their costs and do so in a way that didn't harm quality overall. But that's a very big picture answer.
That's a key point, actually, because we got to really look at that in more detail because that is critical. If we can actually lower costs, hospitals still maintain their margins, and the quality of care remains consistently high. That's important.
Yeah, I would just caution us to think about labor costs in that context, and what somebody gets paid in Rhode Island versus what somebody gets paid in even Worcester.
We are currently doing a deeper dive, as requested by Dr. Cutler, to say what costs did they cut? What costs following that grew more slowly than others? And we have now the detailed cost data in all states to be able to shed some light on those questions. It's a great question.
I was just going to add something along the lines of what the secretary said, which is that's a little bit of a sort of pre-nursing shortage kind of result, right? Where you sort of think that the hospitals have some monopsony power, so they don't have to pay market wages. Maybe they're paying over market wages for whatever, experienced personnel. But now we've seen that lots of those experienced personnel are either leaving or retiring or going to other states or other jobs or something. Mm-hmm. So I think we just have to be a little careful about how much that would apply to current circumstances. Not that it's not worth doing, but just we want to make sure that, we're not going to say on the one hand, hire people and on the other hand, but you can't pay as much as they're making elsewhere.
And sure. And I'll just add one additional thought to this really complicated and really important question when we're talking about potential, spending. Is that providing value in terms of quality and access? One of the things with regard to the ambulatory surgery centers, there is evidence that ambulatory surgery centers provide great quality care in terms of the services they're providing, comparable to hospital outpatient departments at a lower rate. Now, certainly there are more complicated, patients that may appropriately need to be in a hospital outpatient department. So you have to think about that. In addition, with more commodity-like services like labs and imaging, I will defer to the experts, but there is not a lot of variation in quality that is correlated to the variation in price. And so as we move into this next section, I would also, think about if we're able to spend less on the very high end for things like labs and imaging that cost 5 times amount of as Medicare, maybe we can actually have some more revenue to give into the healthcare system in areas like primary care and behavioral health care, areas that might provide more value to patient care and health outcomes. So I do think it's not just about creating necessarily savings, but maybe even redirecting revenue to the places that are going to provide the greatest value. And I think that's a nice tee up to where we go.
It's a perfect tee up because the slide that we're looking at right now actually shows primary care spending in the orange bars per member per year. And we can see from 2017 through 2021, there was about a $40 increase, 7.6% increase in spending for primary care. And then in the blue, much bigger bars, we see all other medical service spending that grew about $950 or close to 22% over that same time period. So if we're talking about wanting to invest more in primary care and spend a higher percent of overall medical spending on primary care, what we've actually seen from 2017 to 2021 is that primary care declined as a percentage of all commercial medical spending from 8.3% to 7.5%. On our next slide, this graph setup might look familiar to some folks, and it would look familiar because the past couple of years for cost trends reports, we have been looking at people, commercially insured residents who have zero medical spending. This time for this chart pack, we're actually looking at the percentage of commercial members with zero primary care spending by their community income. And so here we have our members or residents who are living in the lowest income communities. And we see in the blue bars that adults are 23% of adults in those communities and almost 11% of children in those communities have zero primary care spending in a year, compared to the higher income communities where both adults and children are more likely, are less likely to have zero primary care spending. Yes, Secretary Walsh.
Sorry, you guys can tell me if I'm annoying. The only thing I would add to this graph, if you also added an axis that had, I don't know how you do this graphically, the payment to the commercial payments to those communities, they are significantly low. So it becomes a doom loop. So if you're a hospital in a lower income community that serves people of color, your Blue Cross rates will be lower. And so and then you can't hire physicians and people leave the community. And then you see this trend that is so graphically depicted here.
That's great. Thank you. On our next,
I just wanted to add maybe a comment and a question for the research team on this one. This to me also appears to kind of have implications for how we do risk adjustment. Because if we're doing risk adjustment based on kind of what we project these communities to spend, here we're seeing that in our lower income communities, that they're not accessing the healthcare system. And right. So if you did risk adjustment just based on what you expected these communities to actually spend, you'd actually risk adjust lower. Right. And so we have to be intentional about knowing this fact when we do risk adjustment, or else you could actually compound the problem. Whereas actually,
it also shows up in cap rates. You're absolutely right, David. You're out. Sorry, I'm going to put myself back on mute. You'll be happy to hear.
Madam Secretary, we're singing from the same hymn book here, and then where we think about the variation in commercial pricing and how that correlates with this exact same graph as the Secretary said. So
yes, agree on all those comments and harken back to the December risk adjustment presentation that we had. Thank you, Director Zell. So on the next slide, we examine the types of services that make up primary care spending. And as I alluded to on the first slide, these are mostly our office type visits, including some chronic disease management and preventive visits. These office and preventive visits make up over 90% of the primary care spending pretty consistently. I'd also like to note that from 2017 through 2021, we see a slight increase in immunizations and injections. This does also include COVID vaccines in the more recent years. And moving on to the next slide, we can transition to behavioral health, our behavioral health spending. So this data is from the CHIA Primary Care and Behavioral Health Expenditures Data Book. And here we are looking at behavioral health spending across several categories of care. I would like to note that for commercially insured members spent most of their behavioral health spending, or 60%, on ambulatory and outpatient care. Overall, not noted on the slide, but overall behavioral health spending made up 8.9% of healthcare spending, but that varied greatly by payer type. And so about 7% of commercial spending was 7% of commercial spending was for behavioral health. It was only 2% in Medicare Advantage and almost 21% for Mass Health. And if you go back to this chart, you can see that Mass Health and Medicare Advantage both had over 30% of their spending in the inpatient settings. If we move to the next slide, here we're going into our all payer claims database and looking at commercially insured population. We're looking at the number of psychotherapy visits per 1,000 members. And here again, we're doing a look by community income level. So to our left, we have member utilization for members who are living in our lowest income communities. And on our right, we have our highest income communities. And we can see across the board that there's been an increase in psychotherapy visits from 2017 through 2021. However, for each year, commercially insured residents living in the highest income communities were receiving more psychotherapy visits, but patients in lower income communities although they had fewer visits, they did experience faster growth. So you can see from 2017 through 2021, all the way on the left, there was about a 92% increase in visits. I also want to note here that we are continuing to track telehealth utilization. We know that telehealth utilization for behavioral health in particular and psychotherapy visits especially has continued to be a main source of a main vehicle for delivering that particular care. And we see, regardless of community income, patients are receiving a lot of their psychotherapy visits via telehealth still. And then on the next slide, this graphic looks very similar to the one that we just looked at. We are showing the same years for psychotherapy visits per 1,000 members, but this time we are taking a look at it by age. And right away, I want to point out that we had more than a doubling, or 131% increase in visits for psychotherapy visits for commercially insured residents 18 to 25. So we see a big increase there. And again, we see high rates of telehealth use across the board. The rate for telehealth use for those 0 to 17 is a little bit lower. If we remember from our prior telehealth work, younger children especially tend to use telehealth services for psychotherapy visits a little less. We had noted that in some prior research.
Laura, can I just pause you on this one, and just the 131% increase in psychotherapy visits for the 18 to 25-year-olds. I mean, that's, to me, just a really striking stat, and you can see the shift to telehealth. And again, looking at these utilization trends and seeing, 2021, these are the pandemic years, every other category of services, most every other category of service had a negative drop. Here we see these increases. And I guess I will raise this question for board members to provide their insights. How much of this is kind of increased ease of access to these therapy visits? How much of this do we know is an increased demand, given what we know and some of the underlying CDC data around mental health trends for youth in particular, increases in reported depression and sadness and suicidal ideation, and as well as kind of expansions by the health plans in terms of making these services perhaps no copay in 2020. Interested in commissioners' thoughts about how we might interpret this massive increase. It appears to me that there's probably a lot of dynamics happening at once, but interested if commissioners have insights. Commissioner Cohen?
Yeah, I'll jump in. All of the above, David. And these trends mirror what we've seen in other data, as you said, from the CDC, from SAMHSA, looking also at suicide attempts as well as deaths by suicide. So not surprising. I think a large portion of this, obviously COVID related. I remember in 2020 talking about that we were going to see a sort of behavioral health tsunami as a result of the traumatic stress that people were dealing with resulting from COVID. So not surprised by these numbers at all.
One question, are these all comers telehealth and regular physical visits? Do we know? Because that might be driving some of the increase because a commercially insured population has access to like the Cerebrals of the world.
So it will be whatever the commercial payer has claims for. So if they have a contract with an exclusively online practitioner, and it shows up in the claims data, we see it. One of the holes in our data that we know exists is that commercially patients are also more likely to pay. In some research has shown that they're more likely to pay out of pocket for psychotherapy services or different forms of behavioral health care. And so we've always been missing that. So here we are really only looking at whatever is actually coming in through the claims.
Yeah, I think that's an important thing for us to keep track of, as we've seen, companies that are kind of doing direct to patient advertising around online mental health supports, and those may not be paid through the insurance company. And so that's going to be something we're going to have to continue to work with. And again, just to say that this data is just through 2021, and here in 2023, I think we know that this trend is going to continue and the demand will continue. And do we continue to have access, and are people waiting longer and longer to be able to access these services? So this is a little data is kind of a canary in the coal mine in terms of what we're going to continue to see in the future and why it's so important to be able to invest in these services.
Yes, just on that point, the Boston Globe had an article today on Blue Cross Blue Shield's behavioral health care utilization. And in that article, Blue Cross had shared that they had seen a massive increase in their behavioral health visits as well going into, I believe, 2022. So another question, Commissioner?
Yeah, just comment. David asked for reactions to all of those issues surrounding the increase in mental health. And I think the one that we're hearing about the most, as well as the impact of social media on adolescents and those in college. And I think more probably some of your health studies and at Metro West, you're probably measuring some of the negative impact of social media on mental health in those particular areas. And again, can't measure that at all, but we can't help but think that that is a large contributor. The isolation, the pandemic, the social media. I've seen it in my community. We've all seen it in the community. So that's just another thing to add. And there are a number of subscription services that are reasonably priced for young professionals or whatever that are outside of the health plan, but they are using that telehealth, better health, and different services like that, which are great because they increase access or whatever, but we're not capturing that data at all.
If we can move on to the next slide, this is also the mental health utilization using our claims data. And this is, here we're looking at the month's supply of mental health prescription drugs. And so here we see just a continuing increase in the use of mental health prescription drugs, and it's increased for all age groups, but there's been an especially large increase, or the largest increase for those ages 12 to 17. It's about a 78% increase over this time period for month supply of mental health prescription drugs. With that, I think I have one more slide that we're sharing today in our behavioral health, the primary care and behavioral health chart path findings, and that's on length of stay for mental health discharges. So from 2016 to 2022, we've seen lengths of stay for those admitted for mental health conditions go from 18.6% for those who are admitted for mental health conditions, those who stay 14 days or more, so 2 weeks or more, the percent of those have gone from around 19% to 28% during this time period. So even though I do also want to note that overall admissions for behavioral health have gone down, and that might be a result of several different factors, including bed closures or unstaffed beds. We don't really know the answer to that. Of people who are still being admitted, more are staying for longer. And in many cases, in 28% of cases, that's 2 weeks or longer.
Okay. Thank you, Laura. Okay, so that was a summary of the
Question,
highlights.
Matt, are detox days in that number?
Or what?
Are detox admissions in that number? Do they show it as behavioral health, or do they show up as physical health?
So this graphic is specifically looking at non-substance use related stays, or not stays where substance use was not given as the primary diagnosis related group. We do have that data we decided to show the mental health specifically because those were getting longer. We didn't see quite the same trends in the substance use data, but we do have that data. Stays for substance use related disorders.
And maybe just worth on this point, just highlighting one important data gap that we have in terms of what hospitals were able to collect this information from, and efforts to fill that gap.
Yeah, that's a great point. So the title of that slide was carefully worded because it is we are currently only reporting behavioral health stays in inpatient acute care facilities and not the psychiatric hospitals. CHIA is working on releasing a behavioral health facility discharge database. And so historically we've had, it's been a hole in our data reporting and understanding of all inpatient psychiatric services and substance use related services, but hopefully, I know she is working on, I know they have a meeting this afternoon, actually, trying to put that data so that we can start using that and understanding trends in not just acute care hospital settings for people who need 24-hour care, but for behavioral health conditions, but beyond the acute care settings. Oh, yes, Commissioner Blakeney.
Thank you. This is very helpful data. Do we know the diagnoses of the extended hospitalizations? That's question number one. And question number two is, do we know the delay, if there's a delay in discharge, how much of that is reflected in the no availability of care in nursing home and extended care programs? Do we have access to any of that?
So we did take a look at the diagnosis codes, and so the top ones were really severe mental illness like schizophrenia, bipolar disorder, and major depressive disorder were among the top. In terms of discharge status, this is we need to dig deeper there. There was nothing immediate. There was no immediate answer in the data, even though the data does this data does provide, you know, where the person was discharged to as part of the data set, but there was nothing that really stood out when we looked at it. But it's something that we also have questions on, and I think they're excellent questions that we need to understand better.
Yeah, I would say, you know, I absolutely think this is part of the story, especially when you look at 2021, and 2022, those increased lengths of stay. We know from just the general patients that are in the hospital that length of stay increased during this time period. And we also know from reports from Mass Hospital Association and others around the number of patients that were awaiting discharge because they didn't have a discharge setting. So even though we may not have the precise data in the discharge file to know were they staying in the hospital because of difficulties in timely discharge, I think we know from a number of other data sources that this is absolutely dynamic, that is happening, and it's likely happening with this population as well.
Thank you, David. I think part of my curiosity here is the comorbidity and the relationship of comorbidity to addictions and to behavioral health, mental health issues, and what impact that has on length of stay, especially if the hospitalization is for an addiction issue versus for another chronic disease. So thank you.
Thank you. Okay, all right.
So let's try to, I will just hit some of the highlights in the following slides and not talk through all of them in the interest of time. Okay, so let's go. So we have 3 more chart packs. This is our hospital utilization chart pack. And here we're showing it as a continued trend from before. Our hospital use in Massachusetts in all the categories of inpatient, outpatient, and ED remain higher than the national average. And that gap is not closing in recent years. On the next slide, we're showing the proportion of newborns that stays that take place in community hospitals has continued to gradually decline from 51% now to under half, 48.5%. Okay, on the next slide, we track post-acute care discharge settings following a hospital stay. And I'll just note that discharges to home health had been growing year after year for a long time. And in 2021 and 22, those have turned around and they've actually been declining. And this, again, is probably reflecting workforce difficulties in the home health sector. It might also reflect on the next slide, a really dramatic drop that I think Secretary Walsh noted in on the next slide, in hip and knee operations that take place in inpatient settings. 40, 50, 60% decline on these surgeries, and many of them are shifting to outpatient sites, as we noted elsewhere. But this is really a big change in care patterns that has implications for a number of trends. Okay, and then we'll move to our price chart pack. Some of the highlights there. I want to show the trend in risk scores as we do. After they had a dramatic drop in 2020, coming from fewer visits to encounters with the medical system and fewer opportunities to record patient diagnoses, they really bounced back in 2021 and basically just continue that upward trend, which is mostly reflecting efforts to code patients, to code additional and more complex diagnoses. And we see the risk score trend in the hospital setting on the next slide, just a smooth trend of, go to the next slide, please. Yes, year after year of the 4 levels of severity for inpatient admissions, The highest severity levels grow year after year, and the lower severity levels shrink. This is just a percentage distribution, and really just an unbroken smooth trend continuing along. On the next slide, we're showing price trends by care setting. The price growth was higher in 2021 than it was in the previous 2 years, and you see that in all settings: the office, the hospital outpatient, and the inpatient especially. Those prices really jumped. And the next slide is showing a deeper focus on the inpatient side, where I'll just highlight the gray and the blue lines, where, as the title says, from 2017 to 2021, total inpatient spending, and this is commercial, grew 12%, even as volume dropped 16%. So as before, more inpatient spending for a lot fewer patients. And that's reflecting those price increases that we just showed. I'll skip the next slide, and then we have several where we are highlighting price variation by provider. Here, for example, for vaginal deliveries and C-sections, there's a variation of about 2 to 1 according to hospital, based on where the service takes place. Variation on the next slide for mammography services is even greater. It's by a factor of about 3 across hospitals. And then finally, on the next slide for lab services, the variation is about 7 to 1, based on where the labs are provided, as we have shown before. And those are substantially over the Medicare price. In addition to showing, sorry, one more slide, showing variation by provider, tend to be as much, but you do see some variation here. And this is even when we control for what provider mix is being seen by the patients with each payer. That variation remains, although it shrinks a little bit. Okay, finally, just several slides in our provider organization performance variation. There's really just a few, and I just want to start with the top line growth in total spending. And this is similar to the measure of spending recorded in the performance improvement plans, but here we combine spending across payers and it's not adjusted for risk scores. So it's the unadjusted total spending by provider group based on where the patients are attributed. And you see MGB there on the top line that has pulled away a little bit from the other providers by 2021. But also important to note is the growth is really high. We're showing in that column the average growth from 2019 to 2021, the average annual growth. So that means 7% growth per year. And all of them are between 5 and 10% growth per year. So that's quite high, and it tends to be higher than some of the previous historical trends. So that's important to note. And then finally, a couple of slides showing some of the variation underneath that TME spending by category. As always, the outpatient category, the orange, has the biggest variation across provider groups. That's where a lot of the variation is. And then one new slide, finally, and the very last one is variation in spending on imaging services. And this is combining both utilization and prices. And we see about 65% difference in spending on imaging services by provider group. And this is adjusted for patient characteristics as well here. Okay. So summary slide, I won't repeat. We've seen the top line data. There will be more in the final chart packs, of course, but thank you for your time. Okay. All right, are there any questions?
Thank you so much. Any other questions from commissioners?
David, on the provider organization variation, are we able to tease out the workforce question there and how much more organizations had to pay as a result of some of the workforce challenges?
That's a really good question. We would be able to learn a little bit about that from hospitals, from that cost report data that we will dig into, but from a primary care or a broad standpoint like that, I'm not sure we'd be able to find that. That's a good question, but I don't think we would know that.
And what we're showing there is the spending differential. So it's not necessarily the cost, the operational costs of those different systems. It's how much claim spending per member attributed to that group over a year period of time. So to kind of follow that logic through, if organizations are negotiating higher commercial price increases to account for higher labor costs, it kind of takes a couple of steps to get to the spending. It's not a direct relation of their costs.
Yeah. Gotcha.
Good questions? Thank you so much. Terrific report and covered a lot of ground. Our next topic is focused on reducing unnecessary administrative complexity, really looking at the policy options and having a discussion amongst the commissioners around the role that the HPC can play in moving this forward. I'm going to turn it over to David South to introduce the topic.
Great. And thank you, commissioners. And just to put a bow on the previous conversation, I know that there was a lot of data we just showed you, and if you can believe it, the report will have even more. But we really do want to work with you in the next few months to help frame and contextualize some of these trends and to really identify the ones that perhaps we're most concerned about, and ones that may lend themselves to policy intervention. So look forward to continued conversations. So for this next topic, I am very happy to turn it over to Kara Vidal to help lead this conversation.
Great, thank you so much. Good afternoon, commissioners. Today, I am here to continue a conversation that we started at the May committee meetings regarding unnecessary administrative complexity, specifically around the topic of prior authorization. I'm going to try to provide today a little bit more background on prior authorization as a policy topic. I'll also quickly recap the presentation that we had in May. That was given by our friends over at the Network for Excellence in Health Innovation, NEHI, as well as the Mass Health Data Consortium, that's MHDC, who were presenting specifically on the opportunity for prior authorization automation. So we'll recap that briefly as well. But then, as Chair DeVoe said, want to really leave a lot of time at the end so that commissioners can discuss automation as a potential policy solution, as well as broader solutions. So on the next slide, you will see that reducing unnecessary administrative complexity is one of the HPC's areas for action in 2023. And then on the next slide, you'll also see that this is a broader topic. We're focused today on wrapping up some of this work with NEHI and MHDC, and then potentially also towards the end of the conversation, looking at other areas where streamlining, simplification, or standardization could reduce unnecessary complexity. All right, so let's start with just a little bit of background. I've shown some of these slides before, so I'll try and go relatively quickly, and please feel free to interrupt me at any time. Okay, so here we're zoomed out a little bit. We're looking at administrative complexity broadly, and I won't read the whole slide. I just want to leave you with three key thoughts here. First is that administrative spending per capita is much higher in the US than it is in comparator countries. The second is that not all of that administrative spending is wasteful. Some of it's very important and necessary, for example, to prevent fraud and abuse and to keep systems running. But there is also a level of complexity and variation that we experience because we have a multi-payer system that increases some of that spending. And then finally, reducing administrative complexity without value could have benefits for the entire system and could be an important way to alleviate some of the burden and the pressures facing providers in particular in this moment. All right, on the next slide, how did we choose prior authorization as the policy priority area that we wanted to start with? This selection actually occurred way back in 2019 when we launched this project. And there were a few key reasons why we decided to start here. The first is that when we talked with stakeholders in the market, this was a top priority area for many of them. The second is that there was at the time and continues to be quite a bit of federal action and other state action on prior authorization. The third is that this is one of those areas of administrative complexity that touches patients directly. Some of the other areas that we considered, for example, credentialing, obviously has downstream impacts on patients, but they're not necessarily as integrated in the process. And then finally, we had a hypothesis that some of the drivers of complexity in this topic area might have broader implications for other topic areas. And so we might be able to take some of the lessons learned about where complexity and variation in prior authorization exists and apply those lessons to other areas of complexity. All right, on the next slide, please. Let's talk a little bit about what we know about prior authorization. So one important piece here is that Massachusetts does regulate several aspects of prior authorization for commercial plans. There are some examples on this slide. I won't read through them all, but for example, payers have to make their utilization management criteria accessible and keep them up to date online. Denials have to be made by a person licensed in the appropriate specialty. There are standards for how quickly payers have to turn around initial determinations. And I should say that this language here is pulled from the statute. The DOI regulation that implements this statute is even more detailed. So for example, the last bullet here is about adverse determinations having to include a substantive clinical justification. The regulation specifies many additional pieces of information that have to be included in that adverse determination notification. Additionally, the Division of Insurance reviews carriers' compliance with NCQA utilization management standards, which were, I should note, I think over 100 pages long in 2020 when we last looked at them. So I just want to make 3 key points here, which is that Massachusetts does absolutely already have some regulation of prior authorization, and we're well ahead of some of the other states. These requirements, however, haven't been sufficient to address some of the key pain points for our stakeholders, which we'll show you on the next slide. And then finally, the third takeaway here is that despite standardizing key elements of the prior authorization process, there's still a lot of room for variation across payers. There are many ways to meet these standards for an individual payer, and so there can still be quite a bit of variety and complexity when you look across payers. Next slide, please. Thank you so much. Okay, so in 2019 and early 2020, when we were starting this work, we did quite a bit of outreach. We talked with payers, providers, we talked with some of the technology vendors and patient advocates. I will say this is a topic people are ready and willing to engage on if you ask them about it. We did hear, particularly from the providers and the patient advocates, some pain points in trying to navigate the prior authorization processes. By far, the top 2 things we heard was about the volume of prior authorizations that they had to deal with and the lack of standardization across plans. So, in that first category, volume, we had many providers and patient advocates, and of course the payers and vendors say, sure, we think that prior authorization is appropriate. It's an important utilization management, safety, spending tool in some circumstances, but the number of things requiring prior authorization is quite high. And the amount of time and staff and resources dedicated on the provider side to navigating that is substantial. And then the other thing we heard most often was about the lack of standardization. So at one point, it was shared with us a list of common orthopedic procedures and all of the payers in the state. And we could just see visually the variation where there were very few, if any, of those procedures where prior authorization was universally required or universally not required. Some of the other categories here are time to approval, so how long it takes to get decisions. I know we talked about that 2-day standard just a few slides ago. I think there's always some additional time when there's back and forth or additional information required, requests for additional attachments, et cetera. A topic of mid-year changes, so the fact that payers can change which codes require prior authorization or the criteria mid-year can just be a lot to manage on the provider side. Concerns regarding retroactive denials after an approved prior authorization. And then finally, some continuity of care issues. So when patients change plans in the middle of the year, possibly having to get new authorizations for existing courses of treatment or drugs that had already been approved by their original payer. Okay. So that was sort of the voice of the market. We next turn to the literature to talk, to investigate what's known about prior authorization. And we break this into 3 sets of slides here. And the first is on spending. And so the takeaway here is that there's ample evidence that prior authorization can reduce spending for the targeted service. And one really important addition to that piece of knowledge came out just earlier this year. And it answered a question that had been on our minds since 2019 when we started this work, which is, we had always assumed that there was a return on investment for payers. They probably wouldn't require prior authorization if they were spending more to complete it than they were saving. But we had always wondered, if you factored in provider administrative costs, if that would still hold true. A really important paper from the National Bureau of Economic Research came out earlier this year. They were looking at prior authorization for drugs in Medicare Part D. And in their study, they found that there was significant savings, even when accounting for provider administrative costs alongside payer administrative costs. So that's a really important piece to consider. We also find that the cost effectiveness of prior authorization can depend. There's not always a clear-cut answer on whether it is cost saving. So in some areas, such as medical imaging or non-emergency ambulance transport, there's been relatively consistent data that prior authorization saves money. In some areas like drug spending, we have found, there was a literature review that we reviewed ourselves that looked at several papers. And there they found that prior authorization for drugs tends to almost certainly reduce pharmacy costs. But the evidence is much more mixed when you look at whether prior authorization for pharmacy, for drugs, reduces total costs or total medical costs. It's not necessarily to say that it doesn't reduce total costs or total medical costs, that the evidence is just a little bit more mixed. And then I think this is maybe an obvious point, but worth reiterating, the cost effectiveness of prior authorization is really influenced by your baseline rates of inappropriate or non-preferred care being ordered. So for example, there was 2 states, Michigan and Indiana, both introduced prior authorization in their Medicaid programs for lipid lowering medications. Michigan saw a significant decrease in spending on those drugs, whereas Indiana didn't really see as much of a change. It was, there was a decrease, but it was not nearly as substantial. Part of that's because the rates in Indiana of ordering of those non-preferred drugs was much lower to begin with, so just less bang for your buck there. And then finally, whether or not any individual prior authorization for a specific drug or service reduces spending, I think where there is stronger evidence is that the complexity and the variation in these policies across payers introduces inefficiency and unnecessary spending, and that is a worthwhile place to target. Okay, the next slide here is on the literature for quality, access, and equity. Here again, a little bit of a mixed bag. Certainly evidence that prior auth can help reduce low value care, can help reduce fraud and abuse, drug interactions, and it can act as a clinical decision support tool. However, there's also pretty good evidence that it can lead to care delay, deferral, or avoidance. Sometimes that's the goal. Sometimes the avoidance of the care is exactly what the prior auth policy intended, but sometimes there is denial or avoidance of appropriate care. There's just one study, I know we've got so many bullets here, I'll just highlight one, which is in the Medicare Advantage program, a investigation by the Office of the Inspector General found that 1% of Medicare Advantage plan denials were appealed, a very small percent of denials based on prior auth. But of those that were appealed, 75% were overturned. And so that raises some concern that there may be other necessary care that was denied but was never appealed. And then finally, there are equity issues here. There has been some recent effort to identify whether when care is delayed, deferred, or avoided, whether that happens at equal rates across the population. And some studies suggest that it doesn't. There's a paper by Austin Fracht and Michael and Kyle that shows that administrative tasks, including prior authorization, are more likely to result in care delay or deferral or avoidance for those with a disability, those who are lower income, and those who have public insurance. And then on the final literature-based slide here, there are certainly impacts to clinicians themselves, clinician burnout, obviously being a top priority for The state and federally, the US Surgeon General has a report to address clinician burnout, and they directly cite prior auth inefficiencies as a driver and call for direct reforms there. I think anybody who's talked to a clinician about this topic has probably gotten an earful as well. All right, on the next slide, moving from the literature into reforms. As I mentioned at the top, there has been a lot of activity in the prior auth policy space over the last 5+ years. Here we've got a couple examples of federal reforms. On the left, there's the appropriate use criteria program. This is a final CMS rule. It was initially, I believe, related to a statute that passed in 2014. It's had kind of a long on-ramp period, but the basic requirement here is that providers have to consult a clinical decision support tool when billing Medicare for certain advanced imaging services. And again, they had sort of delayed the full implementation here, but in theory, the idea was that outlier physicians whose ordering patterns did not match the clinical decision support tool recommendations could be subject to prior authorization going forward. It's almost like a reverse gold carding, where gold carding says everyone has to do prior auth, but I'll make some special exemptions for high performers. This is almost a, in lieu of requiring prior auth, we will only require it for those outliers of lower performance. In the middle example here, this is a recent final rule. It was passed in April. The big headline here is it clarifies that Medicare Advantage plans can't use prior auth to define narrower coverage than traditional Medicare, but it also does some other things. It establishes continuity of care protections for those switching plans, and it sets some standards for how long a prior auth should be valid for. And then finally, all the way on the right, this is the automation proposed rule. It hasn't been finalized yet. If CMS is to finalize it in its current form, it would become effective January 1st, 2026. And it would require certain plans, specifically Medicare Advantage plans, Medicaid and CHIP managed care plans, and the state Medicaid agencies, along with certain qualified health plans that doesn't include those in Massachusetts, to automate prior authorization. And that was a part of the presentation that NEHI and MHDC gave in May, and I can recap that briefly in a few slides here. On the next slide, you'll see there's also been a lot of action at the state level. I will not try and go through all of these, but broadly, we've defined sort of 4 big buckets of reforms. On the top left, removing prior auth requirements. These tend to be very specific, targeted at a certain service or drug, typically done in the Medicaid or dual eligible space, not as common commercially. If you move down, that's the gold carding piece. You may have heard of the Texas gold carding law, which requires that payers give a gold card or an exemption from their prior auth process to payers whose approval rates, their prior auth approval rates for certain services are at least 90% or more. Interestingly, a couple other states are following suit, Colorado and West Virginia, but there's some variation in what has been defined as a high approval rate. It's lower in Colorado, it's at 80%. It's higher in West Virginia at 100%. In the top right box here, this is aligning prior auth criteria. So only one example we found here, this is Vermont, and here they've directed their all-payer ACO stakeholders to evaluate opportunity for aligning and reducing prior auth requirements. So an evaluation piece of work here, not an actual requirement at this point, but still exciting to see. We'll be tracking that. And then other common reforms in the bottom right here related to timing, electronic portals, information accessibility. You can see several states acting in these areas. Next slide, please. Massachusetts has also had some reforms in the past, and there are some proposed reforms currently open in the legislature. On the left-hand side, Chapter 224 included a requirement that payers develop and use standard request forms. There are now several of those forms for specific conditions available on the DOI website. In COVID, the Division of Insurance directed payers to relax some of their prior auth requirements, both to help minimize burden on providers and to help with patient throughput in the system. The Mental Health ABC Act, which was recently passed, prohibits prior auth for acute mental health treatment. And an oversight on my part, we forgot to list here and also a recent law signed by Governor Baker that would create a exemption process for step therapy requirements as well. And step therapy often considered sort of an extension of prior authorization, as well as the work that we've been collaborating on with NEHI. And then on the right-hand side, some proposed reforms here currently in the legislature. I won't go through all of this, but some new reporting requirements, a requirement for commercial payers to adopt automated prior authorization, sort of in line with that CMS proposed rule, and a proposed prohibition on carriers from using prior auth in certain circumstances, including for generic medications and for services that have low variation in utilization, low denial rates, or that have an evidence base for the treatment or management of certain chronic diseases. Next slide, please. Thank you so much. All right, so here we come to very close to the end of my talking and turning it over to you for your reactions and thoughts on where we might go from here. So I'll just very briefly sort of recap the policy reform piece here. So as we laid out in May, we've been working with NEHI and MHDC on the topic of prior authorization. Their most recent work with us was related to automation. And one point they shared, and that we can confirm because we attended all of their meetings, was that there really is a good amount of consensus in the market on the benefits of not only automating prior authorization, but doing it collectively as a state in a uniform, standardized way with defined goals and milestones. NEHI and MHDC, as part of this project, developed a particular set of recommendations for how we could build on the CMS proposed automation rule. And that proposal has three key parts. The first is apply it to commercial payers, because the CMS federal rule does not do that. The second is developing a statewide roadmap that would guide uniform implementation. A lot of technical detail, a lot of decision points about timing and interim milestones, who has to go first, what services are prioritized, et cetera, that could be agreed to as a state rather than individually for one payer or one provider making different prioritization decisions. And then the third key recommendation was to establish supportive structures such as technical assistance center, stakeholder task force, and financial assistance. We don't think this is a solution for all prior auth pain points, but it really could introduce some process improvements, and some of those are listed here. I'd be happy to get into them further if helpful. And then on the next slide, and this is where I will pause. There are other reforms, as we just went through at the federal and state level and what's been proposed in Massachusetts. Automation is one tool. It's certainly got some momentum federally. It's most likely to be finalized by CMS at some point, but it's not the only potential solution on the table. And so we've put up again those pain points that our stakeholders had identified and listed some of the examples of what we've seen that could be used to address those pain points. So I'll pause here and turn it back over to David and commissioners for some discussion.
Great, thank you, Kara. Just a brilliant presentation on all of the nuances here. And so I think at this point, we really wanted to open this up to commissioners to have a discussion about, one, what are their thoughts about continuing to pursue a recommendation around automation of prior authorization? And then two, to go beyond that, are there other priorities that you would recommend to us as staff and to the HPC to be able to continue to pursue and advance this agenda and what those opportunities may be? So I will turn it over to Chair DeVoe and open it up for conversation.
Yeah, thanks so much. And I will echo David's comments on terrific presentation. So I think comments in the two categories. What do commissioners feel that David mentioned? What do commissioners feel about the existing stream of work and our support of that? And what might be other areas of focus? Yeah.
So I've followed this fairly carefully for the past couple of years and have spoken a lot with the Nehi folks and with a number of other folks. So just a few points. The first point is on the prior authorization part, I do think we should go ahead very rapidly. My understanding is that the legislature has to do some things in order for that to happen. And my thought is that we should recommend to the legislature that they do that very strongly, that they should do that they should enact those. I think the system is ready for it. They've come together around it. It is an area with more pain than dollar savings, but that's okay. It's great to start with things that reduce pain more than necessarily the dollar savings would mean. That's an important component. And so I just think it's kind of there, it's ready, it's been investigated. We should be able to go ahead and do that. I don't think we should stop there because there are a lot of other administrative expenses. Amongst them are things like, many of them are not things that involve interactions between payers and providers, but they're things like the website at most healthcare organizations is so awful that everything has to be done by phone. And that means that you're hiring a ton of people to answer phones and use sticky cards to say, little yellow note cards with workarounds for everything, instead of like investing in capacity to do things better. Some of those are things that we can do outside of this process. We can do some benchmarking. Some of it are things that just we can provide technical assistance to various organizations. So I think there's a fair amount in addition that we can do, but I don't want to hold up making progress on areas where we can make progress. And I think trying to do the whole thing at once, trying to wait to do the whole thing at once would be a big mistake. And it just seems like people really are ready for this and they want to, so we should go ahead rapidly on the prior authorization front and also keep going on some of the other areas.
What's our sense of the barriers to moving rapidly on the prior authorization work? Is it funding?
I would say at this stage, there really does need to be some legislative action on the prior authorization front. We can continue to convene and have voluntary efforts to do automation, to streamline, to standardize. And I will leave it to others to judge whether voluntary efforts will have the same urgency as perhaps some legislative changes, and would offer that, this may be a topic that the board would want to make a policy recommendation in our upcoming cost trends report, specifically to policymakers and to the legislature about potential opportunities in prior authorization.
I think some of it is that in order to get the benefits, you have to have more insurers doing it because you still need to keep a lot of staff around if some insurers are not doing it. So the basic thing that you need to automate it is you need the payer to be able to look inside EMR of the EMR of the provider. And so like if you're only going to approve the thing if the patient has had a poor experience with a previous therapy, you need something to be able to look inside the record to see whether the patient had poor experience with that previous therapy. And so the standards now exist for doing that, like where the data live and stuff like that. But what you need to do is make it clear, like, okay, all the providers have to use those standards, and then all the payers have to go ahead and do this. That way you don't have to keep an army of coders on hand in case some payers decide not to do it or something like that. So it's really about saying, okay, we're all going to identify the data so that you can look it up. You can just dial in whatever and look up what's going on inside the record for that patient and then just go ahead and approve it. And that's how you get the sort of real-time part is you don't require the Xeroxing and the faxing, and even if you do all the electronic submission, there's still a human being that's doing all the electronic submission and the days that it takes. It's what you want to do is get it to be instantaneous, like when you put your card in the reader, your credit card, it sort of instantaneously charges it and that thing is done. And so that's where you need to get to, and you need it to be kind of universal to really get a lot of the savings. And so that's, I think, where the legislature comes in, is in that universal part.
So let me play back what I'm hearing, which is that there's a general agreement amongst providers, payers, and certainly amongst consumer and patient input that standardizing, simplifying, automating prior authorization would be a plus, but the likelihood of that happening across every payer and provider voluntarily in the same time frame is low due to all the different priorities and areas of focus, both for their investments and for their human resources. So the likelihood of this happening without legislative requirement is lower. So the question for us is, do we want to make that recommendation? Any other thoughts on that by other commissioners? I think this is an important area of focus for us to make that recommendation, both because this was such a priority and concern even before COVID. As Kara said, this was a priority of ours in 2019, but it's only been amplified by the concerns around workforce, both in terms of having the resources to staff for this, but also the level of frustration that's being experienced. And when we think about the percentage of time that the provider offices, let's hold aside the health plans, because obviously they've done an evaluation of whether the time investment is worth it. But in the provider offices, this is now becoming one of the factors in the challenges around workforce. So I think it's even more important now than it was in 2019, and is worthy of our recommendation and focus. Other thoughts on that? Any commissioner that has a concern about moving forward with recommendations along those lines, or other comments on that?
Seems right to me.
Okay. So what I'm hearing is
We're seeing a lot of head nods on.
is support for moving forward to make recommendations as Dr. Cutler and Director Saltz outlined to the legislature. So moving to other areas that we think would be useful. Other thoughts?
And can we maybe just move to the next slide?
I'll just voice this one over quickly if helpful. There are some areas on the right that have been on our list of potential focus areas. And on the left, you see some of the potential markers of how you identify complexity without value. Not an end-all be-all list, but things that take clinician time or attention away from a patient, technology constraints or limitations, things where the cost to perform the task maybe outweighs the benefit, or things that have to be repeated or done differently to accommodate non-standard forms or processes.
And any insight, Tara, on what would pop to the top in terms of impact when we think about examples, impact and feasibility?
Oh, that's a great question. I think impact and feasibility might be, unfortunately, not in the same. They might be opposite ends of the spectrum. I'm looking through here. I mean, I think electronic health record interoperability actually spans a lot of different topics and is related to prior auth automation as well, as exactly as Dr. Cutler was saying. It involves the payer ability to pull data directly from the electronic health record. It can also be used to do things like streamlining quality reporting and all sorts of processes. So depending on how you define that, there's quite a bit in that space.
That was the one I was gonna choose as electronic health record interoperability. And I'm wondering if, and I know we have methods of doing it, but when they have different EMRs, it's also difficult. You know, and so we end up repeating labs because we don't have the information on our fingertips. And so that's, if we need to move faster, that's what we end up doing before we wait to get them.
I'll just throw in a plug for provider credentialing. I hear, particularly among mental health clinicians, frustration around credentialing. I know some progress has been made, but I think there's still room there as well.
So just a few thoughts. One is we should probably have a little more of a process to figure out where to go, because I think all of these are valuable. My sense, again, based on some knowledge, which I don't know that it's 100% accurate, is the biggest dollars are in the first line here.
Yeah.
The billing and the claims processing. So those are all the people whose job it is to make sure that every possible thing has been coded so that our risk scores can go shooting through the roof so that we can get paid a ton of money and stuff like that. And so that, and then the denial of that and all of that back and forth, that's where a lot of money is. So if we were going for the money, we'd go there, but that's also a very big thing.
Yeah.
And in some sense, the easier things to think about are, I think, where Marty's mind went, which is the sort of credentialing and the directory management and stuff like that. Those are all simpler because those are things like, okay, let's, you know, if you're credentialed by one, then, you know, you ought to be credentialed by another. If you're credentialed in Rhode Island, you ought to be credentialed in Massachusetts or whatever it is. Those kinds of things tend to be easier. I'm also have the sense that these are not a full list of the areas. Like there still are a lot of other administrative costs. Again, those things that are not between one party and another, but within parties. And so I might almost say that we should, I mean, maybe what the mode committee ought to do is try and talk to some folks and try and formulate a plan for what we would do after we did prior authorization. You know, where is, you know, talking with Mihai and others, where are the next logical steps, or at least what are the choices that we would have as the next logical steps? Because I, you know, just sort of, I love throwing darts, but I'm not a very good darts player.
Yeah, I agree. It sounds like what we could use as a deeper dive into that trade-off that Carol was saying is a complex one, the balance between impact and what's really going to make a difference and how feasible it's going to be to implement, and perhaps come up with recommendations, short-term and longer term, that are broader and that we can add to our recommendations to the legislature as well. Let me suggest that we take Commissioner Cutler up on his offer to take this to discussion with members of the MOAT committee and other organizations that have been involved in this and come back to the board with recommendations. Commissioner Blakeney?
Thank you. Thank you, Deb. I absolutely agree with that. The one thing I would suggest is to make sure that as we look at each one of these areas and issues, we try to figure out how we talk to the people who are actually on the ground floor doing some of this work, and whether they see changes in process or changes in impact that they can recommend, not unlike what we did when we looked at the prior benefits. Who was the group that we had that conversation with? Pardon me. And what information can we get from them on a continuing basis to hear what other things they feel are important and suck up time from them. So I would just add those two components to your suggestion. Thank you.
Other additions or subtractions to the recommendations for moving forward? Okay, great. Well, more to come. We'll come back with further recommendations on what we can pursue beyond automating prior authorization, and we'll move forward on recommendations to the legislature around how to further the prior authorization work that's already been recommended. Right. Any other last thoughts?
First of all, just to say thank you to the board for your thoughts on this and hearing continued support for making this part of the HPC's agenda, our policy agenda this year. Commissioner Blakeney, I appreciate your comment about actually kind of getting on the ground and talking to people. And I was just reminded that we actually had a number of site visits scheduled for March 2020, where we were planning to go on the ground and see how these systems and processes play out in kind of on the ground at different provider organizations. Obviously, those site visits had to be postponed, but I think an opportunity to revisit this. And so as on this next slide, as shown here, do see some opportunities to move forward on the prior authorization where there continues to be, has been our focus. There's been some consensus, not complete consensus, I want to acknowledge, but certainly an interest across market participants. And so we will be back to the board with some potential recommendations this year, as well as a path forward moving into the rest of the year. So thank you for that. And at this point, I'm ready to turn it over to our final kind of substantive agenda item, which is really an update to this board on an important topic that has been kind of a mainstay of the Health Policy Commission's agenda for a number of years, which relates to out-of-network and surprise billing. And we wanted to really both provide a little bit of a background to some of our newer commissioners about our history on this particular topic, why we had persistently identified this as an opportunity for policy action at the state level, to give an update on the federal No Surprises Act, and just some remaining thoughts about where the state still might have an opportunity to lead. So I will turn it over to our out-of-network billing experts, longtime Kate McCann. Thank you for leading this work.
Thank you, Director Seltz, and good afternoon, commissioners. This slide shows a roadmap of today's presentation, which will focus, as David said, on implementation of the No Surprises Act. And as we have a fair bit of material to cover, let's jump right in. On the next slide, out-of-network billing has been a long-time policy interest of the commissions, but I'll provide just a quick refresher on background to begin. On terminology and scope, when we're discussing out-of-network or surprise billing, we're specifically referencing two scenarios at the core. When a patient receives out-of-network care in emergencies, and when a patient has gone to an in-network facility for non-emergency care, but while there inadvertently receives care from an out-of-network provider. Such care might come from an anesthesiologist, radiologist, assistant surgeon, or other types of ancillary providers. These concerns raise significant consumer protection concerns with respect to fairness to patients, as well as financial impact and affordability concerns in connection with potential balance billing. But out-of-network billing is also a sort of twofold policy issue. There are also important implications for market functioning. On a system level, the absence of limits on out-of-network charges for emergency care, for example, can affect negotiating dynamics between market participants. Providers can leverage higher out-of-network rates to negotiate higher in-network rates and impact overall spending and ultimately result in higher premiums. The HPC has made repeated recommendations in cost trends reports to enhance protections for consumers and enact a solution to address the related market dynamics. In recent years, there's been a definite increasing focus on this topic around the country, both state and federally. And in 2020, there was a federal law enacted with bipartisan support called the No Surprises Act. Next slide, please. So the No Surprises Act, or NSA, was signed into law by President Trump in late 2020. And while the law contains a great deal of detail, we're highlighting just a few key background facts here. First, the protections we're discussing today went into effect almost a year and a half ago for plan years beginning on or after January 1st, 2022. Next, with respect to patient protection, the law protects patients in out-of-network emergencies, which includes post-stabilization, and for certain out-of-network care at in-network facilities by taking patients, quote, out of the middle, meaning they're held harmless and their liability is limited to what it would have been had the services been rendered by an in-network provider. Providers cannot balance bill the patient for the difference between the reimbursement they receive and their out-of-network charges. And I'll note here that the NSA also establishes a notice and consent exception, but it is not applicable in what is sort of considered the core services here. So ERAP providers, neonatology, et cetera. And there are different policy approaches to answering the resulting question of fair and reasonable provider reimbursement, as evidenced in various state laws. The No Surprises Act takes a procedural approach and established an independent dispute resolution process, an arbitration process, which went live just over a year ago in mid-April 2022. Much more to come on IDRP in the following slides. But before we get there, I want to emphasize another scope point, which is that the No Surprises Act is noteworthy because it reaches both fully and self-insured health plans. State laws only apply to fully insured health plans due to ERISA preemption, with the potential exception of state laws that allow self-insured plans to opt in. But the point being, a federal solution was needed for comprehensive patient protection. Finally, on this slide, a note on ambulances. Air ambulances, which are federally regulated, are in-scope providers under the law. But the law also established an advisory committee to consider ground ambulances, which we'll touch a bit more on later in the presentation. On the next slide, please. As promised, we are going to dive into the IDRP. So let's begin. One of the headline takeaways from early implementation of this law is that there have been many lawsuits filed challenging various aspects of the law and implementation thereof. We're focusing on 2 of them here today, but as a framing point, I note that there are other lawsuits, including, for example, one challenging the administrative fees established by the federal agencies. Before we get to the key litigation updates, though, as a baseline, the blue box at the top of the slide includes some important reminders about how the IDRP is structured. First, the law requires that parties negotiate for 30 days after initial payment or denial thereof. Should a dispute remain after that, the law establishes baseball-style arbitration, meaning that each party submits a final offer and the IDRE, or Independent Dispute Resolution Entity, which is making the determination, must select one of those final offers. The IDRE cannot come up with a new amount. Second, the law prescribes information the IDRE must consider in making a determination, which includes the QPA, more to come on that term in just a minute, as well as additional information submitted by the parties. Finally, by contrast, certain information is prohibited from consideration. Charges, usual and customary rates, or public payer rates, including Medicare and Medicaid. So a bit more on the qualifying payment amount, or the QPA. It's a term that plays an important role in the law. It's used in calculating patient cost sharing, as well as here in the IDRP. It is generally equivalent to a payer's median in-network rate as of a certain date scaled for inflation, and it's calculated by payers according to specified methodology. Now, following enactment of the law, 3 federal agencies, HHS, Department of Labor, and the Treasury, commenced rulemaking to implement the law. They released an interim final rule pertaining to the IDRP in September 2021. In that rule, a rebuttable presumption was effectively established, whereby IDREs must select whichever of the parties' final offers was closest to the QPA, again, the median in-network rate effectively, unless certain criteria were met. Providers challenged that rule in federal district court in Eastern Texas in a lawsuit referred to as TMA-1. There are 4 Texas Medical Association cases, arguing in that case that the rebuttable presumption put outsized weight on the QPA. Without getting too far into the weeds of the lawsuit, the defendants, the federal agencies, argued that the overall statutory scheme supported the rule and that they were entitled to deference regarding agency statutory interpretation. As part of the ruling in favor of the plaintiffs, the judge agreed with providers that the rebuttable presumption was unlawful because it contradicted the statutory text and held that the departments had ascribed additional material terms in the rule that were not in statute. Accordingly, the court invalidated the relevant provisions, and I'll just note quickly that in a separate lawsuit, parallel provisions were vacated with respect to air ambulance IDRP later in that year. So the department subsequently issued a final rule in August 2022 with new requirements for IDREs. And this past February, 1 year after TMA 1 was decided, the same judge ruled in favor of the plaintiffs in TMA 2, in which providers alleged that the new requirements continued to unlawfully tilt in favor of the QPA. In summary, the judge held that the final rule continued to put a thumb on the scale for the QPA and invalidated the relevant provisions, which pertained to the order of QPA consideration and a credibility standard for non-QPA information. And this was held over the agency's arguments that the rule imposed reasonable evidentiary and procedural rules for IDRP. So that is a lot of legal lingo, but the last two bullets really reflect the overall takeaways and current status. The departments have revised the information and guidance in accordance with the court's rulings, including a directed pause on IDRP for a time. But at this point, all IDRP processing continues. The QPA remains one factor the IDREs must consider, but it is not given any particular emphasis or weight. So I just want to pause for questions here before we turn to some of the data that's been published on the IDRP. See if there's any questions. Let the lawyers talk about lawsuits. Okay, if there are none yet, turning to the next slide, notwithstanding the various legal challenges, IDRP carries on. So what can we learn from the first year of the process, or first year or so of the process? The departments have published initial reports and status updates, technically 3 status updates, and they've been clear that these reports are initial or partial, and that publication of supplemental information is anticipated down the line. Nevertheless, the first key takeaway so far is that utilization has been very high in comparison to what the departments estimated. In the first year, shy of a couple of weeks, over 330,000 disputes were initiated, which is nearly 14 times what the agencies estimated for a full calendar year. Next, eligibility reviews have been a primary cause for delay. This is a very complex process for which the departments have procured additional support for the IDREs. As you can see, the non-initiating party often challenges eligibility, but notwithstanding that, IDREs must confirm eligibility in every single case. And to give a sense, they must resolve a jurisdictional question as to whether the federal IDRP applies or whether state law governs. And for a state law to govern, the law must apply to the insurer, which may include a review of whether a self-insured health plan has opted in a state where that's an option. The state law must apply to the specific out-of-network provider, and it also must apply to the specific item or service in question. Eligibility review also addresses completeness of information, compliance with timelines, and correct batching of claims as may be applicable. It is a complicated analysis that seems to be improving somewhat with additional guidance, technical assistance, and increased familiarity with the process, but nevertheless has caused a bottleneck and resulted in a backlog of cases. Finally, on this slide, the departments continue to work on implementation and, as mentioned, anticipate additional reporting, including eventual quarterly reports with all required data elements.
So can I just make sure I understand the incidence of dispute? So if we think about all of the determinations that were made, what percentage were disputed? So it was 334,000, but that what percentage is that of the total?
334,000 is the total number of disputes initiated. So are you asking about eligibility disputes?
Well, how many decisions were made? In other words, I'm trying to understand the frequency of dispute. Is it 10%, 20%, 30%?
Of all the services that are within scope of the law? I don't know the denominator. It's a good question, but where I thought you were going is how many payment decisions were made, which we have some information on the next slide.
Okay.
But I'm happy to clarify other questions on this slide if you have them.
I think just understanding what percentage were disputed And then of those, how many were eligibility disputes?
Mhm.
Sounds like 37% were eligibilities.
I think it's maybe a little bit higher. 30, that figure represents instances in which the non-initiating party, sort of raised a hand and challenged eligibility.
I see.
But eligibility has to be reviewed in every single case. And I will say, I don't remember the numbers off the top of my head, but in the beginning of the process, the number of cases that were closed for ineligibility was high. I want to say upwards of maybe 70% at first. In the quarterly data that they've released, it has decreased. So, which would, sort of lend us to believe that people are beginning to learn more about the process and the rules. But quite a few cases were dismissed as ineligible, particularly in the very early part of the process.
Thank you.
Sure.
Kate, do we have information about, you said there was a 30-day window where they're intended to negotiate prior to initiating the independent dispute resolution process. Are the feds reporting about how many are resolved in that 30-day window?
Not to my knowledge. The mandated reporting elements are on the dispute resolution process. So if you're settling before that, there is no process. So to my knowledge, or at least to this date, I haven't seen anything publicly available on that.
Yeah, I mean, just the fact that the departments anticipated much lower amounts of these dispute resolutions maybe indicates they thought that there would be more of the negotiation and settlement in that 30-day period. And it seems like people are instead opting to try to go to the IDRP process, which again is complicated, administratively burdened, comes with fees attached to it.
Correct.
So is adding cost into the system. So you can go on to your next slide.
Yes, I think that's all fair. So on the next slide, we have a few sort of by the numbers, if you will. So you may be wondering, of the 330,000 disputes or slightly more than that were initiated, how many payment determinations were made? How many payment decisions were rendered so far in the process? And the answer is just over 42,000. And that's out of a denominator of over 106,000 closed disputes. And disputes can be closed for reasons other than a payment determination. So that gives a sense of, of the entire universe of disputes that have come to this process. Decisions have been made in slightly over 42,000 of them so far. In the upper right, we've included some Massachusetts data. In the first 3 quarters of the IDRP, 1,447 disputes were initiated here. As a frame of reference, in the first 2 quarters, Massachusetts was 18th in terms of overall disputes initiated. Texas had the most with nearly 25,000. And in the 3rd quarter for which data is available, Massachusetts was 29th. Texas was still number 1 with just over 25,000. Of some interest, a handful of states, both at the top of the list and the bottom of the list in terms of overall disputes initiated, have state laws that would apply to many of the payment disputes, which is just interesting because it's possible that many of the disputes involved self-insured plans that are not subject to state law, and or it also could just reflect confusion around the process, sort of harkening back to the eligibility review discussion we just talked about. Finally, on this slide, the bottom statistic pertains to the IDRP overall. So this is not Massachusetts specific, to be clear. As of March 31st of this year, approximately 71% of payment determinations rendered were decided in favor of the initiating party. That statistic, coupled with information in the initial reports that the vast majority of disputes were initiated by providers or facilities, provides our first glimpse really into how this process is playing out. And so far, it appears that providers are winning disputes more often than not. On the next slide, stepping outside of IDRP and information from the federal agencies, the Robert Wood Johnson Foundation and Urban Institute recently released a brief focused on the consumer protection aspects of the law. IDRP was not in scope for this report. Given that implementation is still relatively new, it makes sense that the study was based on interviews with a range of regulators and stakeholders. I won't review this in detail, but some key takeaways are included here, and I'll just highlight the positive note that the interview participants generally agreed that patients seem to be well protected by the law. And the report also reflected the perspective that it's too early to really evaluate certain long-term impacts. On the next slide, we zoom in for a minute from the federal landscape and offer just a few notes from the perspective of the Commonwealth. Underscoring here that the No Surprises Act, again, is in effect. It's protecting patients in both fully and self-insured health plans here. Next, we offer a reminder that just days after the No Surprises Act was signed into law, Governor Baker signed Chapter 260 of the Acts of 2020, which addressed out-of-network billing, including creating some additional transparency and disclosure requirements for payers and providers in non-emergencies. With respect to out-of-network provider payment, Massachusetts does not have its own law, and therefore the federal IDRP is utilized here for payment disputes under the No Surprises Act. In informal discussions about IDRP to date, local payers raised a variety of concerns, including but not limited to confusion surrounding the process, lack of effectiveness of the negotiation period, and questions around how the QPA is being considered by IDREs in practice. And finally, in the last bullet here, while Massachusetts does not have a state law establishing out-of-network provider payment, a reminder that Chapter 260 directed EOHHS in consultation with partner agencies to develop a report and make recommendations on establishing one. And the next slide provides a refresher on that legislative report, which was published in 2021. It included a variety of information and analyses recapped in the first bullet here, and ultimately concluded based on key findings that notwithstanding the No Surprises Act, the legislature should establish an out-of-network default rate for emergency and non-emergency care for the fully insured market in Massachusetts, and further suggested consideration of an opt-in for self-insured plans. The recommendation was to establish the default at the median in-network rate, subject to possible further regulatory definition, and to be evaluated after a reasonable time period. As noted in the blue box at the bottom of the slide, in the 2022 HPC cost trends report, the HPC called on the legislature to enact the recommended rate as a constraint on the spending and market impact of excessive prices charged by out-of-network providers. So to wrap things up, and before we take further questions, we wanted to provide a brief update with respect to ambulances. You'll recall I mentioned that air ambulances are in scope of the No Surprises Act, but the law established an advisory committee to consider ground ambulances. The committee's work is finally underway, with the first meeting held on May 2nd and 3rd, which covered a lot of ground, if you'll pardon the pun, including an overview of the industry, payment systems, billing practices, and potential regulatory and legislative options to prevent balance billing. And their charge, which is summarized here, is due within 180 days of the first meeting. And finally, the second half of the slide notes that a number of states have addressed or are working to address ground ambulances and out-of-network billing. Several states have some type of solution in place with variation in approach, scope, applicability, et cetera. But a couple of examples are mentioned here, including Washington, where a group is working to determine how to prevent balance billing in this space and whether to recommend that ground ambulances be folded into the state's existing balance billing law. Additional state efforts were identified in our recent chart pack on ground ambulances, which we published this spring, including Vermont and Maine. And as a final, very recent example, I'll just mention that a bill is on the governor's desk in Texas that would prohibit balance billing, and health plans would be directed to reimburse at the rate set by local government entities, or for communities that lack such rates, the lesser of charges or 325% of Medicare. So pending enactment, that's just one other example of a state approach in this space. And I think that the takeaway is just really that states are continuing to think about these issues, and there's keen interest in monitoring the federal advisory committee's work as the year proceeds. So that's quite a few updates, but I'm happy to take questions if there are any.
And perhaps I'll just tee up this part of the conversation, and thank you, Kate, for that great presentation. You know, I think there are questions here for the board around, do we continue to make recommendations around having a default payment rate in Massachusetts? When we made that recommendation, or when the EOHHS made that recommendation and we affirmed it in our cost trends report, we noted the potential benefits of not having to go through an IDRP process, which adds, you know, additional time, complexity, and cost into the system. And that a more simple and streamlined approach of just using the median commercial rate while, has some complications involved with it too, but would provide a more predictable and streamlined way for adjudication of payments in these circumstances for both the providers and the health plans. Interestingly, I think some of this early evidence from the No Surprises Act raises to me some additional questions. On the one hand, we really, in that EOHHS report, had identified the median commercial rate as the default payment rate in order to align with the emphasis that the federal government had on the qualifying payment amount. Those were essentially trying to be linked. And now we see that the federal approach has had to really move away from the QPA being kind of a measure of import in the dispute resolutions. We've also seen from some of this early evidence that there have been a lot more of these processes than perhaps the federal departments anticipated. Hard to say if that's happening at the same level in Massachusetts. As you said, we kind of seem to be a little bit in the middle of the 50 states. And so, and then I think an interesting question, which is, where states have put these places, their own provisions in place, does that potentially create more complexity in terms of these eligibility reviews and then having to kind of track back patients? And so I think, these are important dynamics, but this is still continues to be, I think, an important area for us to look at. So, question to the board either today or as we continue to move forward and learn more, do we continue to see a potential role for state policy to help kind of streamline and clarify these processes, as well as maybe provide coverage for the remaining gaps, ground ambulance being a particularly important one. So with that is just a little bit of framing, and happy to take comments today, but also know that we've laid a lot of information on you, but I wanted to raise those dynamics.
Great, thank you so much. Yes, Patty. Oops, you're on mute.
Sorry, I was just looking for some procedural clarification. So when a health plan receives a claim, and in your instance, you talked about an anesthesiologist being out of network, how is the claim processed? What is the patient seeing when they get the EOB back? They're going to see their in-network charges taken care of. Is that out-of-network anesthesiologist taken care of in that same initial claim, or what happens at that point, I guess? What is the patient seeing?
I will do my best to answer your question. I think there's sort of two parallel things. One is that the patient should see nothing more than, a bill for their in-network patient cost sharing level, whatever that may be. But that is the extent and the limit of which a patient should be involved in any claims processing here or adjudication thereof. In terms of the actual mechanics of the claims, I don't have a great amount of detail, except that the law does require the payer, the insurer, to make a payment within a certain time frame, it might be 30 days, of receipt of a clean claim from the provider. So they either have to make an initial payment or they sort of deny initial payment, and that begins the domino effect of the process laid out in the law, whereby, there's this negotiation period that you have to go through, and then if there's a remaining dispute, one of the parties can initiate this process. So hopefully that answers your question. The whole, at the crux of the protection in this law is taking the patient out of this entirely, so that they're only getting a bill for what they would have gotten had they intentionally opted to receive this care, either because it was not an emergency or because they, did their homework and went to an in-network facility and they didn't know the, assistant surgeon was going to be out of network. So they should only see a bill for their in-network level, and then the insurer must pay on the claim and kick off this process. Does that help clarify at all procedurally?
Oh, absolutely. That's what I was hoping you were going to say. So that's great.
I think there is maybe an underlying interesting question, which is, does the patient then have transparency about what the final payment was, even though they're not necessarily having to pay that, but do they receive to say, oh, at the end of the day, your health plan paid $10,000 for that service?
Yeah,
which I don't know.
I think that is a good question. And one of the things in the Robert Wood Johnson Urban Institute report was sort of a question on, gauging consumer awareness level of this. I mean, there's this tricky dynamic that if patients are being protective, they don't really know much about what's happening here, which is a good thing for patient protection, but maybe hard to assess how much is known to whom and when from a consumer perspective. So, yeah.
Commissioner Foley?
Thank you. Yeah, definitely a lot of information being shared, and I think a lot to think about and review and dig into. And part of that for me is understanding a little bit of the last point that you were making, David, about how would a state law interact with the federal law? Where are there gaps, and what would we want to do given the No Surprises Act and what we've learned? And I guess my question for discussion or for further information sharing would be, what other states have been doing around the same issue? Are they adjusting and thinking about it differently now? What are the lessons they learned and how are they applying, and how might those approaches help inform either a continuation of what the recommendation has been in the past or an adaptation based upon the No Surprises Act and how it's playing out and what we might be able to do or learn from others that are thinking about similar issues?
Yeah, I think it's a great point with a great question embedded, and maybe just as a data point, I think there are 22 states that have what's called a specified state law under the law or an all-payer model agreement like in Maryland, but 22 states, those are called bifurcated states. So it means that depending on the item and service in question, it may be subject to state law or it may be subject to the federal process. That's part of that eligibility review question. But there are 22 states where there's that sort of question of, there is a state law and does it apply? And 6 of those states, I think, allow self-insureds to opt in, and there's variable uptake in the different states around that. But I will say I have seen, and I wanted to mention some of those state laws, many of them, in fact, predate the No Surprises Act, and existed before this federal law. So I think you're right that a lot of states are figuring out how to adapt or pivot or modify. One that comes to mind immediately is Washington, where they have an arbitration process established for their own state law, and they've done a lot of work to figure out how to harmonize them, how to modify, how to react as this, federal law has been implemented. So I think there are things to learn from other states, to be sure. And I wanted to also mention in the bifurcated states where there are state laws that apply to certain services, air ambulances are not regulated by the state. So there is, the federal IDRP is utilized for those at the very least, even if the scope of other services is covered by state law. So there is a matrix here, sort of no matter what, I think, but definitely things to be learned from looking at other states.
Thank you.
Dr. Castillo?
I guess what I'd like a lot what Dave said about I worry about the amount of time that a provider is spending doing some of this arbitration. And I think he said, and Dave, tell me, you said that it would be better to have a set rate for what we do, and that's what we could, can you tell me that again, Dave? Because I worry about that piece, how much time we spend doing the arbitration.
Yes, exactly right, Commissioner. The recommendation that we had was to just, set a default payment rate that would not be subject to kind of a back and forth in arbitration. That would be tied to the median kind of in-network commercial rates. And, I do think I think you raised an important point, which is talking to providers here too. Kate mentioned that we did talk to a few of the health plans to get their initial reactions. I do think we do need to do the similar thing on the provider side. And I will share perhaps a concern, maybe very hypothetical, and I'm probably getting over my skis on this, but I could imagine that there are certain organizations that are groups of emergency room physicians or radiologists, anesthesiologists that we know are often subject to these out-of-network provisions, who may be quite sophisticated in challenging, every single denial and build that into their administrative processes. And would other providers who maybe don't have that kind of infrastructure around them be able to take advantage? And so even by the process of creating new administrative processes, are those being equally available to everyone, or are certain organizations seeing that they can, if they challenge everything, they'll get 60% of them overturned in their favor, and so it's going to be worth it. And again, that's a little bit of speculation, but we know that some of these organizations are for-profit organizations that have existed and have taken advantage of the pre-existing market dynamics around out-of-network in the past.
So I'm where Dr. Castillo is, which is like, we don't need full employment for lawyers through arbitration, and we don't need to go creating a bunch of administrative costs where there's no need. I mean, we just had a lengthy discussion about removing administrative costs. So here's a very clear opportunity where we can go ahead and remove administrative costs. So let's just go ahead and do it.
Yeah, I agree. I think having a default rate would eliminate a lot of confusion. I think where it bears further discussion is what should that default rate be? Because while I see the logic of using the median rate, it would build in different rates for different health plans based on where they were and their history of paying for certain services. And that adds its own complexity. Yeah. So you put forward a couple of different options for what that rate would be. But I think, and we could look into that, but I think the more critical question on the table is, do we agree that default rate versus versus arbitration is still a worthy goal for our state and something that the HPC should pursue and recommend?
And just to add to that, I think hearing some support that this is a continued area of interest for us to dive into, we will keep it on our agenda. I would say in terms of you raise the important point, what is the default payment rate? That is the crux of the the biggest decision. Everyone has always been in agreement of taking patients out of the middle of these situations and not having them to be faced with surprise bills. But how do we fairly and reasonably reimburse providers for the services that they're providing? That has always been a key point, and certain states have taken different approaches to that. I think as part of the development of our the EUHHS report, which did go to the default commercial inpatient in-network median rate, was the alignment with the QPA. And so now that the QPA is perhaps not as an important of a tool on the federal side, although remains to still be a little bit seen, maybe there's an opening to consider others. But I think given this conversation, we'll continue to keep it on our agenda and bring it back for future conversations. And certainly when we talk about policy recommendations.
Great. Are there any other thoughts before we close on this discussion? Any other thoughts, clarification, or comments? Okay. So we'll look forward to further discussion on that. And now for our last agenda item, I'll turn it over to David for the Executive Director's report.
Thank you, Madam Chair, and thank you, Commissioners, for this marathon board meeting. I will bring us home with a number of updates that I wanted to share in the next 15 to 20 minutes. So first is our traditional slides around material change notices. On this slide, you can see the frequency of the different material change notices. On the next slide, we have 3 transactions that are currently under review by the HPC. So first is a proposed clinical affiliation between Emergency Physician Associates of Massachusetts, St. Vincent Hospital, and Metro West Medical Center. St. Vincent and Metro West are both owned by Tenet Healthcare Corporation, a national for-profit healthcare system. Emergency Physician Associates, or EPA, is an affiliate of Team Health, which is a national healthcare staffing and management company. Under the proposed transaction, EPA would become the exclusive provider of emergency department services for both St. Vincent and Metro West.
David, before you move on, yes, as part of our review, are we investigating whether they would be an in-network or out-of-network?
I would think that would be an important question, given just the conversation that we had.
Given what we just discussed, yes.
I don't know if Kate is on the Zoom.
Yes, we are indeed looking at network status as part of both of the transactions involving emergency physicians.
Yes. And aptly, the second one here is also around emergency physicians, which is the proposed employment of emergency medical clinicians by Newton Wellesley emergency medicine specialists by MGB. The Newton Wellesley Emergency Medical Medicine Specialists is a private medical group, and under this affiliation would become the emergency medicine physicians and advanced practice providers would be employed by MGB and would provide emergency services at Newton Wellesley. And third and finally is a proposed clinical affiliation between Beth Israel Lahey Health affiliated entities, Beth Israel Deaconess Medical Center, Harvard Medical Faculty Physicians, Mount Auburn Hospital, and Cambridge Health Alliance. BIDMC, it's employed in physician group, the Harvard Medical Faculty Physicians, and Mount Auburn are all corporate affiliates of BILH. Cambridge Health Alliance is a contracting affiliate of BILH. And under the proposed clinical affiliation, they would expand on a longstanding affiliation between BIDMC, the Harvard Medical Faculty Physicians, and Cambridge Health Alliance to now include Mount Auburn Hospital. And the affiliation, a clinical affiliation, would include a coordination of healthcare services. So all three of those transactions are under review. If commissioners have particular questions as we continue those reviews, please reach out to us. So, hi, Tim.
Hi, David. How are you? Sorry, I'm taking the charge of what would Don do or say at this moment. Just again, I think we've talked a lot about looking back at some of the prior transactions that have been approved and the impacts those have had. And so this last one kind of sparked my thinking of how do we think about this transaction in light of the prior transactions that have been approved and our commitment to reviewing some of those and holding up meeting all the standards that have been set forth and what the impacts have been, and just want to kind of make sure we don't lose that piece of our review and how this might play into it.
Excellent. Thank you, Commissioner Foley, and you channeled Commissioner Berwick quite well. Yes, that is absolutely on our agenda, and I appreciate the support for that. So for the next executive director's item, this is something that I've introduced as kind of a regular, again, agenda item on our executive director's report, just to briefly give an example of how we are intentionally incorporating a health equity lens into all of our work. And so it's just 2 slides, and I'll turn it over to Laura just to give a highlight here about how we're thinking about this with our data sets and our research team.
Thanks, Director Seltz. I'm excited to be here to talk about this today. This is very much research methods in development, a little behind the curtain to what we're doing on the research and cost trends team. Something that has come up at multiple meetings and, both public and within the HPC staff is the need, when we're talking about health equity, understanding a baseline of where we're starting from, understanding what health inequities currently exist. And it's come up again and again that some of our main data sets, our administrative data sets, that may not have some of the that often do not have some of the information we would like, including information on race and ethnicity, sexual orientation, gender identity, immigration status, and a variety of other factors we would want to consider or know about when trying to understand where we should be trying to improve. A lot of those types of information actually comes from survey data, and we're quite lucky in the state to have the Massachusetts Health Insurance Survey that Chia puts on, and we get a lot of information from that. But a lot of our research actually comes from our all-payer claims database and our acute case mix databases, which are our hospital-based databases. And those databases have, in particular, the claims data has much more information on healthcare utilization and spending than any survey data that we do. And so what we're doing here in developing new research methods for us to use internally, although these have been used in other publications, is trying, we're taking one data set, our case mix data set that actually does include information on race and ethnicity for members of the Commonwealth or residents of the Commonwealth who have an emergency department visit, observation stay, or inpatient stay at an acute care facility. And we are getting an incidence. We can go to the next slide. We're actually going to try to understand the incidence of certain events, and using our all payer claims database, we can better understand spending, cost sharing, which is a very important part of understanding what is the burden of paying for this healthcare directly out of pocket, and people's access to follow-up care. We are going to look at this by race and ethnicity after, again, these hospital-based utilization. And so for our inaction portion, one of the things that we're thinking about examining is adverse birthing morbidity events by race and ethnicity. So in this instance, we would look for these adverse birthing morbidity events by both race and ethnicity and payer. And this would provide us a baseline incident of these events in the state. And then we can then use the all payer claims database to calculate additional healthcare costs overall, and also to the individual person or an estimated person, and what kind of follow-up care they got for both commercial, in the case of maternity or birthing events, we're mostly talking about commercial payers, and we could use the Mass Health information from the Mass Health fee schedule to understand Mass Health specific spending as well. Happy to take any questions on that, and happy that we are highlighting some of our new research methods.
Thank you, Laura. And I think there is a broader agenda across multiple government agencies, including CHIA and UHHS, around standardizing data collection methods on all of the variables that you mentioned. And that is a very important ongoing work. I think what we want to highlight here is that we're not waiting for that, and we are trying to innovate with the data sets that we have, even with our limitations, to bring in these important aspects into our examination and cost trends work. So moving forward, as this is our June meeting, I did want to provide a little bit of a mid-year update. And given the time in the meeting, I will kind of give an overview, but this may be something we will return to at the next board meeting to continue to talk about. But we've had a very busy 5 months at the Health Policy Commission, as noted on this slide, in terms of the number of meetings and publications. I was blown away by the almost 1,200 different participants who were a part of our healthcare workforce event, both in person and online, earlier this year. You can see some other important stats from our investment programs. But I would just note, in terms of the cadence of public meetings, there was a stretch from end of January until the end of April, which was the busiest stretch of public meetings in the history of the Health Policy Commission. So to that, I would say thank you, commissioners and board members who participated in all of those meetings, events, special events, and I think really reflective of the important topics that are facing our healthcare system right now, from healthcare costs and affordability in our benchmark process to the healthcare workforce, which has been an increased focus for us. Skipping forward 2 slides, returning to the 5 areas that we had identified at the beginning of the year for particular attention and focus. And so the next few slides gives a little bit of a status update on each of these key points. And so for the first one, around bolstering our cost containment activities, you know, in many ways, our agenda here continues to be one of advocacy with the legislature and the administration around some of those necessary statutory changes to evolve our approach around the benchmark and the accountability to the benchmark. I would note that we held a very good hearing on the cost growth benchmark directly with the Joint Committee on Healthcare Financing. We were able to talk about some of those recommendations and have, I thought, a very robust conversation about how we can evolve our approach. did end up setting the benchmark at 3.6%, along with a conversation among the board members around continuing to investigate ways about how we appropriately apply that. So we've been in a lot of conversations with the administration and the legislature, as well as other constitutional officers around our recommendations. At the same time, we're continuing to evolve our internal approach to reviewing entities that have been referred to us, given the disruptions during the COVID. We are ongoing monitoring of the MGB performance improvement plan. I'll have a more robust update for you on that at the next board meeting, and continue to collaborate with other states around their benchmarking efforts. On the next slide is our summary of the work on healthcare workforce challenges. As I've already said, this has been a top focus of conversation throughout the first 5 months. And we issued, I think, a very well-received report and chart pack, as well as held a widely attended event to discuss these solutions. And again, I also then dedicated an entire meeting of the HPC Advisory Council to discuss workforce solutions as well. So all of that is kind of in the completed box. On the ongoing box, we're working with CHIA on new survey data. We're continuing to work on our investment programs around different ways of delivering care. And importantly, have been really working closely with this UHHS and Special Advisor Sung on other opportunities that we can work with the administration. We also finally identified for future research work, diving specifically into the primary care workforce, which was not a focus of our initial report. The next slide is the same status update around our health equity improvements. And again, these are not comprehensive of all the things we've done, but certainly some key accomplishments so far. First, we did update our ACO certification program with an enhanced focus on health equity capabilities. A part of our telehealth report at the beginning of the year talked about access and equity with regard to telehealth use. And we're really been proud to support the Health Equity Compact in the development of their first ever Health Equity Trend Summit, which will be next week. A lot of ongoing work in the areas of data collection, as has already been mentioned, performance metrics that we anticipate including in our cost trends report, and working again with the administration. We do see some opportunities later in this year around how we might design a new investment program, specifically with regard to health equity. The next slide is on enhancing pharmaceutical pricing and transparency. Here in the completed bucket, we did have issued new research comparing US pharmaceutical pricing to international pricing. That was new and novel research, as well as a data points that in part looked at out-of-pocket costs for prescription contraceptive services. Here too is an area where we really are continuing our advocacy for legislative changes necessary to fully incorporate the pharmaceutical sector into the state's oversight and accountability processes. I would note that the legislature and the Joint Committee on Healthcare Financing had a robust public hearing just yesterday discussing many of the proposed legislation that would implement some of the exact changes that we've been recommending. Our future agenda here is a little bit more in the research space and how we can continue to use data to highlight different dynamics in the pharmaceutical space. And then finally, our status report on administrative complexity, which I don't need to review, as we spent a good portion of today's meeting talking about what we've completed and where we're going. So that was my mid-year status update. I happen to take some questions, and Commissioner Blakeney.
Just a quick question, David, on the workforce issue with the advisory group. Did I understand you to say that conversation has already happened, or is it slated to happen?
So it has already happened.
Okay.
So we held our last advisory council meeting. We dedicated the whole hour and a half to just really be talking about where we should go next. I think we have a summary of that meeting that we can share with commissioners. I would say there was widespread agreement that this is, continues to be a really important topic facing kind of the entire care continuum. They had definitely identified opportunities for coordination across state agencies and even across secretariats, even outside of UHHS, And I know that's continues to be a priority for the Healy Driscoll administration. We did hear support for our proposal around kind of tackling primary care as our next research topic. So I got a lot of support there.
Great, thank you, David. I'd love to see the report when you have the opportunity.
Yes, we'll definitely share that. So in our final 5 minutes, I think we can make it. Wanted to just brag a little bit about some of our internal work, and I'll let Hannah describe some of our newest members of the HPC staff for the summer.
Great, thank you. So the start of summer at HPC means it's summer fellowship season again. HPC launched our summer fellowship program in 2015, and over 9 summers, which includes this summer, we've been joined by 88 students from around the world for this 10-week program. Our fellowship program offers students enrolled in a full-time master's, PhD, law, or medical program the opportunity to engage in a standalone policy or research project within one of the HPC's 5 different departments. Fellows work with the team that they're embedded within to develop a project that aligns both with their academic interests and also meets the HPC's goals and mission statement. In addition to their primary project, fellows are offered a host of programming and networking opportunities, which allows them to better understand some of the different facets of the HPC's work, some of which includes meeting with HPC commissioners. So thank you all for doing that in the past summers, and thank you in advance for doing that this summer. Also joining policy discussions with HPC staff and key stakeholders, attending public meetings of the HPC's board and committees, touring the Massachusetts State House, and volunteering alongside HPC staff at Boston-based nonprofits. So the program starts in June and ends in August. And if we can go to the next slide, I will do a quick shout out and welcome to our 2023 class of summer fellows who are watching our meeting now. This is their 3rd day of employment at the HPC, and we threw them right into a board meeting. So we're very excited to have them here. And one other thing that I'll mention about the fellowship program is it's been a really great tool for recruiting for the HPC as well. A lot of the members of our fellowship class have been recommended to apply to the HPC by colleagues and former fellows who are either their classmates or that they work with. And we have a number of full-time employees who actually started with the HPC as summer fellows. So that's been great. And if you are interested in learning more, we do a recap report every year about the projects that all of the fellows engage in, and they provide kind of a write-up and some reflections. And so all of those are on our website, which is mass.gov/HPC.
Thank you, Hannah, and shout out to our fellows for joining this summer. I would just also add, in addition to recruitment, many of these fellows go on to work in other healthcare organizations, both within Massachusetts and across the country, and we've created a pretty incredible network. And while this program is some amount of work, the value is tenfold in terms of what we get as an organization out of it. So looking forward to working with these fellows and commissioners for you, hopefully getting the chance to meet them soon. So finally, wrapping up today's meeting, a couple of upcoming events. First, want to highlight the Health Equity Trends Summit that I mentioned earlier. This is going to be held next week. It is open to the public. We're going to have a couple of commissioners participating in this agenda, as well as myself, who will be on a panel with other state leaders. Encourage commissioners, if you're interested, to attend or to share with your networks. And on the next slide, this is our anticipated agenda for our next board meeting. We're going to continue conversations on the cost trends report, specifically around policy recommendations. We're going to return to that white paper on pediatric market trends, and we'll likely have an executive session to begin review of this year's confidential referral list to the Health Policy Commission. So more to come on a busy July board meeting. A reminder that the cost trends hearings, we did adjust the date for this. So please, if you have not already, adjust your calendars. It is November 8th. And then finally, on the next slide, our schedule of upcoming meetings, both board and committee. We will see you all again on July 12th. With that, my phone reads 3 o'clock, and so I am happy to turn it back over to you, Chair DeVoe, to close out this meeting.
Perfect, right to the second. Any last questions, comments, observations from commissioners before we close? If not, thank you for a very productive session, and we